Well, we are heading over to our SWAC also chapter in that part of the world, and we are so lucky to have Ibrahim Hassan really moderating this whole thing, and I have to compliment Ibrahim especially for organizing all the speakers and moderators for this session. You did such a nice job, and we're really looking forward to what everyone has to share. So Ibrahim, the floor is yours.
Thank you very much, Christine. It's a real pleasure, really, to be part of this fantastic group to really celebrate the memory of Professor Bartlett. It's been an incredible journey, and I remember his quote in the last conference we had in the SWAC also, that saying that, 10 years from now, I will say 100 years now from now, and even more, people will receive the ECMO therapy, but they will not know what happened behind the scene. From all the research, all the hard work that people have put together, but we as a clinician will witness that. That's what he quoted, and it is inspiring. But also, obviously, we all remember Speranza, the Hope, the first case that survived with Professor Bartlett, and I wanted to share a small video of cases that will continue to inspire people going forward and to keep this legacy going, not just through us, but through the many patients that we had. And I would like to share briefly my screen for to show a very short video, really, and then we'll go through the introduction of the team. Share.
And share sound too when you share your video.
Start broadcasting. Is it working now?
Not yet. Okay, I see it. It's kind of small. If you can make it bigger. There we go.
Okay.
When I see the building, I first of all think about myself, that what happened to me there, and I got out. Similar to me, many people are there in the hospital. They are having many problems. I would like to tell that anyone who's having problem or something, it will finish if you're strong by your heart and you have faith. It was very bad. I couldn't walk. I couldn't, it was hard to breathe also. In that time, I went to the hospital, Hamad, Al-Wakra. They said that you have influenza, some kind. So I remember nothing, but I had dreams. When I opened my eyes, I saw this red pipe going from here and one into my leg. I was kind of frustrated, like, why I'm here? So when they removed the ECMO, that was the first happiness, the best happiness I had. Now, alhamdulillah, I can feel like I can breathe well. Without ECMO, I wouldn't be alive today. Those doctors who took care of me and those nurses, thank you very much.
Good job. Good job. Okay. That's okay. That's okay. That's okay. Because of moving, that's okay.
When I see the building,
I will stop sharing the screen and stop sharing. So just wanted to highlight, this is one example of many. And as I said, this legacy will continue to live through the people, through the medical team. But more than that, it's not just about the technology. It's something that brought us together, I remember building the ECMO program. It just pushed the boundary for critical care. You really need to get the best out of the best and set as an exemplary to transform the entire critical care structure, really. That was the beauty of ECMO, to get these people together, and not only just within a hospital, within the regions. No, SWAC also, we are the youngest chapter, and started in India, obviously, with the Sunil and the group, and slowly spread it to the Middle East, and then went to Africa. And we are a very large continent. We are very young. We have so many patients that we need to treat. And education and training is something that the team took in their shoulder as their mission, to spread this knowledge that was started in Ann Arbor by our godfather. And again, this is a continuous journey. Many of us and new centers, they did not have that privilege and honor to train by Bob, and we envy the team that actually done that. They work with him side by side. But even for those of us, some of us who never worked directly clinically with him, he touched us in everywhere. And the SWAC also is an example. We had a lot of struggle in the beginning, but look now, where are we? We are united. We are one team, working shoulder to shoulder. Everyone, despite everything that's happening in the world, we all come here together. It's 5 in the morning in Qatar. In India, I'm not sure how long it is. What's the time? In different part is a different time, but people are coming together, celebrating his life and legacy that continue through every one of us. We are fortunate to have now several outstanding speakers from the region. We could not get everyone, although there is many experts in the field. And we start where it started. It started in India in our chapter. And we have our first speaker is Dr. Arban Shakabari from Critical Care from India, Apollo Multi-Specialty Hospital, who's giving us the first talk. Dr. Arban, you are welcome to start. And after our first session, we have four speakers, and then we'll have question and answer session. Dr. Indira, also from India, Dr. Nader, Karma, as well as Dr. Marlies from South Africa. So, Dr. Arban, welcome on board. Pleasure to have you, and thank everyone really for short notice coming together. And I wanted also, before we start, just to highlight the role of Nick Barrett, who came up with this great idea, Kristen, Peter, and the people who's been working now almost 24 hours supporting behind the scene every single speaker from all this continent to make this memorable experience for everyone. Thank you, Dr. Arban. Welcome. The stage is yours.
Thank you, Ibrahim. This is a great opportunity. Now it's 7:55 in India, and thank you all. So this is my talk is on ECOR, the extracorporeal CO2 removal, and probably with a machine with two missions. Now, obviously, I don't have any conflict of interest. So this journey from ECOR has been started pretty long in 1978 with the handholding with Theodore Colombo and Luciano Gattinoni, who has started thinking that whether this carbon dioxide can be taken out extracorporeally by using some membrane in the animal model. And they have found that this spontaneously breathing patients, if you decrease the alveolar ventilation, was proportional to take out the carbon dioxide by the membrane lung. And they found it useful in some problems like uncontrolled bronchopleural fistula, and those are on artificial ventilations are contraindicated. Then this idea has been extrapolated by Gattinoni in an experimental study with an carbon dioxide removal system with a low frequency, as much as the tidal volume can be reduced in ARDS. So now, henceforth, the idea of ECOR is just to have a lung protective strategy apart from the carbon dioxide removal. Now, JAMA published this paper in low frequency positive pressure ventilation with extracorporeal support in severe acute respiratory failure. This is also with the Gattinoni's brainchild, and this has shows some way of doing things, how to protect the lung. So there are 43 patients who are entered in the control study designed for this, and there was a significant outcome came out of this. Now, ventilatory condition, like expected mortality because of this more than 90%, and then always occurred with 48 hours, there is an improvement showed. Now, how this hypercapnia is going to fail us in the due course by increasing the pulmonary vasoconstriction, it increases the mean arterial pressure, increases the RV afterload, and led to acute cor pulmonale. Now, if you see in supernova study by Dr. Coombs and Ranieri, they have also made it possible by feasibility and safety of ECOR to enhance protective ventilation, and they tried to go over ultra protective ventilation of tidal volume of 4 ml per kg in ARDS. And what is there at primary endpoint was the proportion of patients achieving protective ventilation with PaCO2 not increasing more than 20% of the baseline. So, and the arterial pH of 7.3. So, and they have used some lower and higher CO2 extraction devices. And what they found that proportion of patient achieving this and reducing carbon dioxide with the tidal volume is 78 to 82%, and 59 patients, 62 patients alive till discharge. Now, with that idea, if you see that we need 200 ml of, we produce 200 ml of CO2 per minute, and we need to have CO2 removal with a less than 1 liter of minute blood flow, which is not as big as for the oxygenation of the body. And if you see, whenever you are using CO2 removal device, there is an initial rapid response and there is a late response. So if your PCO2 is 100, 100 to 80 will be rapid, then there will be slow decline. And we have multiple CO2 removal devices, starting from arteriovenous to venovenous. And optimal condition should be patient should be hemodynamically stable. The MAP should be good and cardiac output should be good. This is a prerequisite for using ECOR in any patient. And this is the thing which is used for arteriovenous system, taken out from the artery and pushing through a oxygenator. No pump is attached and pushing into the vein. This is a CO2 removal device. This is AV ECOR. Now, we should concentrate with this model of doing ECOR that is known as decap method. You have a lung membrane and the hemofilter in series, and you are taking out the carbon dioxide by using the sweep gas flow. So this is your thing. And there are some points which you have to see how they are doing. This membrane, lung, and hemofilter is coupled in series. They enhance the performance of each other. They minimize the need of heparin by the blood entering the membrane lung by recirculating the plasmatic water. And as the membrane, the filter is down stream of the membrane, so there is an increase in the pressure so that the CO2 removal is good. And this is the model what we use. We take out the blood from the patient and it goes through a membrane lung and then goes through a hemofilter. And this is probably the system of how we take out, use a blood pump. And this is going to show you how we use a dialysis machine on a ECOR for the ECOR to happen. Now, this is one of the things coming in a very big way. There is a Prisma lung, which is a CRRT machine with an inbuilt CO2 removal device, which is connected here. So you have this filter and you have this ECOR, your Prisma lung, which will take out the carbon dioxide as well as a part of the CRRT. Now, coming to a case, this is a patient of severe ARDS, and you can see the numbers when the CO2 and the ABG, with the CO2 is going up to 89, pH is going down, and slowly the oxygenation is good with the proning and other things, but CO2 could not come down. So this is a case of a moderate ARDS with a PCO2, high PCO2, and we have started this patient on ECOR with the filter, with the dialysis, and this is a machine which is connected here, and you can see this is the oxygenator which is connected. And how they are connected, and this is your Mackay oxygenator, the pediatric oxygenator, which is connected here, which is again with the downstream of the hemofilter. And it should be there's a blood in and blood out, and this is the sweep gas, which is reducing the carbon dioxide as a fresh gas flow. Now, coming to this case, this is a case of severe asthma with a good amount of air entrapment. And this guy actually had a severe carbon dioxide retention with a pH of 7.26. The PCO2 came up to 93. The PO2 is maintaining with the minimal oxygenation. And the PCO2 is very high. And we could not ventilate this guy, though the oxygenation was fine. So we could attach this dialysis machine with a inbuilt CO2 removal device like a pediatric oxygenator and just connect it to the patient. And you can see that slowly it is coming down. And because of the severe asthma, we had to use this sevoflurane apart from other bronchodilators in this patient. And this is a patient. And slowly this, if you can see over the period of time, the CO2 is coming down from 93 to 42. And slowly, we could run this CO2 removal for almost a day 9. And the lungs started improving, and we could put him on pressure support, and the CO2 normalized, and we discontinued the CO2 removal. And you can see the monitor which showing the PCO2 of ETCO2 of 39. It was 70 initially, and slowly he actually improved after that. Now, this is a fantastic thing, the ECOR, which is used in the cases of patients where in severe COPD, where we don't want to intubate those patients. This patient came to us almost the 9th time in the emergency with a PCO2 of 120, and he's completely drowsy. He was previously admitted almost 8 times in the hospital. The relative doesn't want to intubate. So what we have given the option, if you can reduce the CO2 a bit and he become conscious, and you can avoid the intubation. So this is another part of the ECOR, how to prevent intubation in case of severe COPD patients who are actually the CO2 retainers. So what we have done, this is known as awake ECOR. We have just started the dialysis machine with the ECOR in this patient, and we could reduce the CO2 from 120 to 70, and he's actually talking as the ECOR is running, and we could stop the intubation. So this is another part, apart from low tidal volume ventilation, assuring low tidal volume ventilation in ARDS. This is another story of ECOR, which will be coming in a bigger way for the COPD patients whom we don't want to intubate, or if at all intubated, we can start ECOR and get them extubated early. So few points. I can see the video is very clear that we are giving this ECOR through the dialysis catheter in the groin, and he's talking. So this is the ultimate slide, which is where we stand for the ECOR, and this is how I do it. We use judiciously in selective hypercapnias. In MODS, I think the results are not good, so we are again working on this with the CRRT machine, if this can be done with the lower flows. Mandatory use of femoral access. I have seen this femoral access is better than the neck access. Probably the patient is sometimes restless, so femoral is less fluctuation of blood flow and the circuit clot. Keep in mind these flows are low. Use of large bore cannula, maybe Parmacath, because we use Parmacath as the cannula device for the ECOR, which is 14.5 French available in our country, and it's a very good thing. We put it femorally and took a very hassle-free CO2, and you can give at least 500 flow through that. You have to use liberal heparinization to keep ACT around 200. So this is most important, because once this clot started forming in the low flow circuit, it is very difficult to maintain. Sweep gas is usually start with 8 to 10 liters, and you can see the CO2, how is the CO2 thing, and you can come down on this. And flow target should be more than 300. Lesser than 300, the chance of circuit clot and the CO2 removal is not very good. So these things, if you can keep in mind, you can run a good CO2 removal in the patients of ARDS as well as the end stage COPD patients. So thank you again, and over to you.
Very much, Dr. Arban. A great talk. It have a lot of feature. We'll have question and answer session shortly after that. So stay with us, please. And thank you for sticking to the time. Our next speaker is Dr. Indira. She will tell us about the meconium to myocarditis, the pediatric ECMO when everything goes wrong. Dr. Indira is a lead pediatric intensivist at Apollo Specialty Hospital, Chennai, India, chair of the pediatric wing of the ECMO Society of India, and National Pediatric Transplant co-conventor. So pleasure to have you, Dr. Indira, and obviously one of the main hosts for last WAC also, which was outstanding really in India. So pleasure to have you. Please, the stage is yours.
Hello, everyone across the globe. I'm Dr. Indra Jayakumar from India. Thank you, ELSO organization and its chapters, Christine, Peter, Dr. Nick, Ibrahim, for this invite. It's truly an honor. 3 moments in the ICU. Oxygenation worsens despite maximal ventilation. The monitor numbers keep falling. Blood pressure drops, lactate rises, vasoactives escalate, cardiac arrest, CPR begins, the room fills with urgency. These moments every team recognizes. ECMO gives us something extraordinary in these moments. Today, I would like to remember the surgeon whose vision made that possible for children around the world. Space, the final frontier? Nay, in medicine, I would say ECMO, the final frontier. The first ECMO survivor was a neonate, Esperanza Hope, a word that has come to define ECMO for millions of children worldwide. Let me share a few children who reached these moments and survived. Because where there is hope, there is life. Sometimes the story begins at birth. Day 2 of life, meconium aspiration syndrome, VA ECMO cannulation in the referral maternity center, transported to the ECMO center, celebrated the first birthday with the caring team. Sometimes the heart stops without warning. Fulminant viral myocarditis, infant cardiogenic shock, VA ECMO initiated, myocardial recovery within a week. A 5-year schoolgirl had chest pain during sports, sudden collapse, cardiogenic shock, VA ECMO. Her diagnosis? Anomalous coronary artery from opposite sinus, surgical correction, now back to play at school. Trauma, ARDS, and impossible ventilation. A 4-year-old fell from second floor, developed traumatic brain injury, ARDS with air leak, small intracerebral bleed, anticoagulation-free VB ECMO, discharged in a month's time. ECMO was heaven sent for a child who developed bronchopleural fistula post-chest surgery for hydatid cyst. Child with severe influenza ARDS, oxygenation index 40, mean artery pressure 40 despite 3 inotropes. A desperate father transports his child 3 hours in an ambulance seeking ECMO. 3 weeks later, the lungs recovered. Severe dengue shock, escalating inotropes, rising lactate, VA ECMO initiated, circulatory recovery in 72 hours, and discharged home. Infant after congenital heart surgery, unable to separate from cardiopulmonary bypass, ECMO bridged to myocardial recovery, decannulated on day 4. When all alarms beep and PICU turns ominously silent, malignant hypothermia and arrhythmias in a 12-year-old child with diabetic ketoacidosis, cardiac arrest, initiated eCPR, ECMO neurologically intact survival. Post-hematopoietic stem cell transplant, lung in crisis, diffuse alveolar hemorrhage, ECMO for lung rest, recovery in 4 days. Adolescent poisoning, severe cardiac and respiratory failure, VA ECMO, a second chance at life. Robotic slide tracheoplasty, 7-year-old with severe tracheal stenosis, surgery performed on ECMO, smooth decannulation and wean. fulminant vasculitis myocarditis in a 4-year-old with antiphospholipid antibodies, rapid catastrophic deterioration, VA ECMO with plasma exchange on ECMO, survival, recovery, and on follow-up. 2-year-old child with life-threatening asthma, cannulated and transported from the referral center to the ECMO center, and off ventilation in 5 days. Each of these children and many others faced a moment when conventional medicine could no longer sustain life, ventilators were insufficient, ECMO became the bridge, be it miliary tuberculosis, scrub typhus, dengue myocarditis, H1N1, aluminium phosphide poisoning. When ventilators were insufficient, ECMO became the bridge, allowing the lungs to rest, the heart to recover, and the body to heal. All different stories, different age groups, the same shared moment when everything was failing. Conventional medicine had reached its limit. Sometimes all a child needs is time, and ECMO gives us that precious gift, pioneered and expanded through the work of Dr. Robert Bartlett, the global ECMO community, the ELSO organization, and its chapters. Thousands of children across the world are alive today, and many more will gain because one surgeon dared to believe that the heart and lungs could rest and recover. That vision became ECMO. That legacy belongs to Dr. Robert H. Bartlett. Thank you for this wonderful opportunity.
Thank you very much, Dr. Indira, really to walk us through this incredible different diagnostic diseases that also in the region like dengue fever and TB and so on. I'm hearing a bit echo, sorry for that, but it's incredible really presentation. Thank you very much. Please stay with us. We will have question and answer session. I'm sure we'll have an interesting question for you. Our next speaker is Dr. Marlies Van Dyke. Dr. Marlies is a cardiac anesthesiologist, intensivist, director of NEDCAR, Unitas ECMO Center, and founder and chairperson of ECMO Society of South Africa. She is actually the president-elect for SWAC also, and we wish her all the luck for her future work with as a president of SWAC also. And she's going to tell us about a unique category of group of patients that really the team in South Africa have done really a marvelous job on managing them, where otherwise they might not be offering the treatment, which is HIV. Her talk is HIV is not a contraindication. ECMO in immunocompromised patients. Marlies, floor is yours. Thank you.
Good morning, everyone, and I want to thank everybody for this fantastic opportunity and for everyone who's made this possible to have this community, because that's what ECMO is all about. It's about the community around the patients as well. So I'm going to talk a little bit about the immunocompromised patient today and what we should be looking out for. So we all know that ECMO for ARDS or refractory respiratory failure is what we use it for. And there's different groups of immunocompromised patients. We're not going to talk a lot about solid tumors, HIV, post-transplant or hematological malignancies. But in the past, this was traditionally a relative contraindication for ECMO due to the very high risk of infections and poor prognosis. So in the study from Jonathan Religer that was published recently, you can see that patients that's immune suppressed still has a much higher risk of dying in hospital, especially in the first 30 days after the procedure, than patients that's immunocompetent. So, but not all groups are the same. So there's active immunosuppression, and then neutropenia and HIV/AIDS. So active immunosuppression is those groups that's currently undergoing chemotherapy, transplant recipients and patients on long-term steroids and immunosuppressants for things like rheumatoid arthritis. So neutrophil count of less than 400 millimeters is considered neutropenia. But then you have the group HIV/AIDS, which is a very diverse group with variable levels of immunity. And they mostly die because of opportunistic infections. So if we look at this study again, you can see that they looked at immunosuppression versus no immunosuppression groups and successful weaning from ECMO. So if there was no immunosuppression, around 60% could be weaned from ECMO. And in the immunosuppression group, 37.5. So, and if you look to the different groups, you could see that solid organ transplant group was the group most likely to be weaned from ECMO. But if you then look to the hospital survival, they only had a 14.3% hospital survival versus the HIV group that had a 45.5% survival, which was almost the same as the non-immunosuppressed group. Matthew Smith and his group did a 6-month outcome of immunocompromised patients. So, and they found that the 6-month overall survival was only 30%, with significantly worse outcomes for patients with hematological malignancies. But there was also a caveat of a time span of fewer than 30 days between the immunodeficiency diagnosis and ECMO cannulation was independently associated with a better 6-month survival. A higher CO2, age, and driving pressure and the lower pre-ECMO platelet count was associated with an increased 6-month mortality. So in oncology, we're looking at around 20 million people every year that's diagnosed with some kind of cancer, of which around 2 million has got a hematological cancer. And there's a complex interplay between the malignancy, immunosuppression, the coagulopathy, and resource allocation. We must never forget the resource allocation as well. So what's the clinical indications in oncology? Well, rescue therapy. Say patient has got acute chemotherapy toxicity or acute pneumonia, then we can use it as a rescue therapy. Perioperative support, high-risk surgeries for large mediastinal masses or any surgery where there's possible cardiovascular collapse. Bridge to therapy, so stable support to stabilize patients with chemosensitive tumors until the induction chemotherapy can take effect, or tumor lysis syndrome support if patients that has massive tumor cell breakdown. So we know that outcomes differ by the different tumors. So we know solid tumor survival to hospital discharge is between 26 to 32%, but elective complex lung resections may have up to a 76% 5-year survival. The hematological malignancies is the problem, with an overall survival for around 32%, where the leukemias are doing even worse than the lymphomas. But the worst group is the post-stem cell transplants, where there's less than 20% survival, particularly in the early transplant area. So we should have multidisciplinary decision-making frameworks where we, as a team, decide which patient will be a candidate to go on to ECMO. And patient selection is critical. Poor outcomes will be predicted by high lactate pre-ECMO, low albumin pre-ECMO, disease states. So progressive or refractory disease is definitely an absolute contraindication, and thrombocytopenia will significantly increase the risk of fatal bleeding. Lots of complications we know, bleeding because of the thrombocytopenia, the chemo, DIC marrow involvement, infection, neutropenia, the immunosuppressive therapy, lines and circuits. So multi-organ failure, prolonged ICU stay, and tumor-related complications like tumor lysis syndrome. So a recent study, the Yelena study, showed there was actually no difference in survival in severe ARDS with cancer, which we should really select our patients well. But what about HIV? Well, around 40 million people are living with HIV currently in the world, around 0.7% of 15 to 49-year-old people. But in the African region, it's about 1 in 30 adults, and that accounts for 2/3 of the world's HIV population. And around 620,000 people die of HIV-related illnesses worldwide. And the incidence of PJP in HIV-infected patients is 1.63 per 100 person years in developed countries. But in sub-Saharan Africa, it's between 19 and 21%, with colonization of HIV-positive individuals reported as anything between 10 to 70%. So, and most patients where their CD4 counts drop to below 200 will develop then PJP. It's a significant cause of death. And unfortunately, even in today's, we have patients either not receiving or failing to comply with the PJP prophylaxis. So the indications for ECMO is definitely the refractory hypoxemia despite optimal mechanical ventilation. So in our center, we definitely, if a patient with PJP requires ventilation, we advise that the patient goes straight onto ECMO. And it's a bridging to recovery. So we see community-acquired pneumonias together with PJP, or influenza together with PJP, and these patients are very, very sick and require long ECMO runs. And only in selected cases is a bridge to transplant. Why do we ECMO them? They have very, very poor compliance, severely hypoxic with a PO2 of around 30 to 35 by the time we ECMO them. An awake ECMO strategy, so extubate the patient, does confer a survival benefit of around 67 versus 40% for intubated patients. You do reduce the inflammatory response, and it is a bridge to recovery. Key prognostic factors is early initiation. If we can get them earlier, it's a shorter run, they do much better. Look for multi-organ failure. If they do have multi-organ failure, much worse prognosis, but also looks for AIDS defining criteria. Unfortunately, we do see a lot of patients with advanced AIDS coming now with PJP. So, and we have been caught out by the Kaposi in the GIT tract that cause massive GIT bleeds, adrenal failure, CMV reactivation. It's good to look at severity scores, the RESP score, or the 2025 equal pneumocystis score that look at the diagnostic and management to ensure quality care for these patients. This is a patient that came to us with PJP. Obviously, you can see she was ventilated with high-level ventilation, arrived in the unit in extremis. We immediately ECMO'd her with SATs sitting around 50 to 55, and only after we put her on ECMO did we see that she had a massive pneumothorax because she had such poor compliance. So relative contraindications is prolonged high-pressure ventilation. We have taken patients up to 18 to 21 days after initiation of ventilation and still had good success. But if there's severe irreversible organ dysfunction or profound neutropenia, the outcome's going to be poor. So case selection is crucial. And the outcome depends on the underlying disease treatability. But PJP is also different in different populations. We know that in the HIV group, patients with PJP actually does quite well. So there's different studies, but the survival is between 50 to even 67%. But in the non-HIV patients with PJP, the prognosis is actually quite dismal. Specific considerations and challenges, infection control. These patients are immune compromised. They're at extremely high risk for secondary infections. Look for reactivation of CMV and herpes simplex. Bleeding versus thrombosis, strict anticoagulation management, and if at all possible, utilize ECMO without intubation. So we put them on VV ECMO. It's early initiation, much better than rescue therapy. We do struggle with some of our dosing, especially for our antiretroviral therapy. This cohort still has a high mortality, and I'm talking both oncology as well as HIV groups. But in selected patients, we can have successful outcomes. Predictors of failure is multi-organ failure, especially renal failure. So ECMO is feasible and life-saving for the selected patients, and it should not be dismissed outright. But careful patient selection and specialized ICU management is really important. Thank you.
Thank you very much, Marlies, for this rich presentation, and again, very interesting group of people that we will, will be taking, I guess, more questions and answer in the next session. Our next speaker is Dr. Nader Karma, who will tell us about One Network, One Standard, building the National ECPR program. Dr. Nader is the Critical Care Fellowship Director in Hamad Medical Corporation in Qatar. He is an ecmologist pioneer leading the education group in Qatar now, internist, pulmonologist, and intensivist background, trained between Canada and US. Welcome, Dr. Nader. Thank you for joining us. The floors are yours. Dr. Nader, can you unmute yourself, please?
Okay. Is it clear now?
Yes.
Great. Okay. I was saying good morning, everyone, and thank you, Dr. Ibrahim, and also organizers for this great event and for inviting me to participate. It's a true honor. And here we're off to an early start today, so I appreciate everyone who came to attend. Today, I was given the task of explaining how to build a national ECPR system using the state of Qatar as an example. I have no disclosures related to this presentation. And today in our short talk, and I'll try to stick to the 10-minute mark or earlier, we will talk about explaining why low flow time and system readiness derive ECPR outcomes, how to describe the features of high-performing ECPR systems, and identify why Qatar is well suited for a national ECPR pathway, and try to compare retrieval strategies and justify the best fit model for Qatar. First, let's start. We all know that the out-of-hospital cardiac arrest is a very lethal entity. The outcomes across the years and until recently remain very poor. The survival is estimated to be 6 to 8%. So this is a major public health problem, and out-of-hospital cardiac arrest lasting more than 15 minutes defines a refractory cardiac arrest, and in 20 to 30 minutes, conventional CPR becomes futile. Even if we compare the outcomes of out-of-hospital cardiac arrest to in-hospital cardiac arrest, we see that there are better outcomes with in-hospital cardiac arrest. But the take-home message from this slide is that if we adjust for the low flow time, there aren't really much differences in survival between out of hospital and in-hospital cardiac arrest treated by eCPR. And this introduces the magical concept of low flow time. Indeed, we know that CPR duration has been associated with outcomes in eCPR, and survival, unfortunately, falls precipitously after 45 minutes of CPR duration. And that's why it's important to start flow on ECMO and eCPR as early as possible and limit the CPR duration to less than 45 minutes. Some studies have attempted to find the optimal cutoff point to switch from conventional CPR and initiate eCPR. And in this study with the ROC curve, we can see that less than 21 minutes of conversion from conventional CPR to eCPR is probably close to an optimal cutoff to improve survival. So the practical question here is that not just can we do eCPR, because obviously it can be done, but the real question is, can we get the right patient to flow fast enough? And that's why this is a systems question. So in this study, and I want to really go into much detail because most of you are very familiar with the outcomes of the cardinal RCTs in eCPR, the ARREST trial, Prague, and Inception. But in this meta-analysis that combined these three major RCTs with other 8 propensity score matched studies, we know that it is clear message that long-term favorable neurological outcome favors eCPR over conventional CPR. But if we have a closer look at these 3 studies and what separates them and why the outcomes of Inception were different from Prague and ARREST, we can see that the time from ARREST to ECMO in minutes was somewhat drastically different, with probably 60 minutes of low flow time demarcating the difference between these studies, with Inception having the longest low flow time. The center volume case per center were also very different. So while Inception was relatively a low center volume study, Prague and ARREST were big centers receiving large volumes. So perhaps we can deduce some determinants of success of successful eCPR systems, that all of them have low flow times of less than 60 minutes. They are high center volume, probably improving outcomes. They have structured activation criteria and trained ready eCPR teams. So these are systems that practice eCPR as a profession and not as an occasional hobby. Why Qatar is uniquely suited, and this is the bread and butter of my talk. So Qatar becomes especially interesting here because while many countries struggle because they have fragmented geography, operationally or institutionally fragmented, Qatar has the opposite profile. It's a relatively compact country. The target population is concentrated in a relatively small corridor. So just to give you a perspective, the distance between these 2 major cities, Al Wakra and Al Khor, it's around 60 kilometers, but 80% of the population is concentrated around a radius of 30 kilometers around Doha. The ambulance service is well integrated. Hospitals belong to the same corporation, and the EMR is shared. That makes one national activation standard, one destination logic, and one audit framework genuinely feasible in Qatar. So what good systems have in common? Good eCPR systems have pre-hospital eCPR activation. They have an on-call perfusionist, ECMO nurse, and physicians. They have a ready primed ECMO cart and ultrasound machine. They generally try to achieve cannulation time from arrival time in less than 15 minutes. The transport-ready CPR device and cannulation in the emergency department or cath lab. Of course, other systems, and we'll touch on that, do cannulation on-site or rarely in an ECMO vehicle. Parallel tasking and team activation, we found this in our experience very important, where we activate parallel teams at the same time, the emergency department, the ECMO and ICU team, and interventional cardiology. So in our system, for example, we have a hotline for eCPR with a dedicated activation phone line with in-house team. Our early pre-hospital alert considers eCPR activation after 3 cycles of conventional CPR and out-of-hospital cardiac arrest and immediately in-hospital cardiac arrest. This is our eCPR criteria for both out-of-hospital cardiac arrest and in-hospital cardiac arrest with our clear inclusion and exclusion criteria. Our eCPR flow for out-of-hospital cardiac arrest activates that by the EMS system after 3 conventional CPR cycles that are not successful. The EMS team on scene will communicate with the National Command Center, alerting them and starting looking for eCPR eligibility. Our in-hospital cardiac arrest shows immediate activation after initiating conventional CPR in the hospital. And then the ECMO team will arrive there on time and consider cannulation depending on the situation as early as possible. Of course, high quality mechanical CPR en route to the hospital or the emergency department is very important as we are cannulating in the hospital. Our machines are primed. The cart is fully stocked in the emergency department with a dedicated ultrasound machine. We have at least 1 or 2 in-house physicians who are fully capable of starting the cannulation process. And we have along with all these parameters, a shared documentation and audit system with a unified post-arrest ICU coronary pathway. So perhaps we can, in the next few slides, look briefly at different retrieval models and what fits Qatar best and what we are doing. What we are currently doing is a direct transport to ECMO center with an in-hospital cannulation. We have a hub cardiac arrest center where all ECMO or eCPR cases are directed to. It's simpler, easier to standardize, and supports higher center volume, which we thought is the best first phase model and the best fit in the state of Qatar. However, other models that we may look into as the system matures further is cannulation on the scene. This has been done in some European countries, like as you see in this picture from Paris, underground or metro. It's the shortest potential low flow. However, it has higher field complexity and needs very mature pre-hospital ECMO capability. And the third model is a mobile eCPR vehicle. Attractive concept, however, expensive and operationally complex and heavy. It may offer less extra value when geography is already compact, as we have here in Qatar or other small comparable countries. Of course, we have real-world barriers, including activation delays, transport inefficiencies, cannulation delays, equipment or ECMO cart not prepared, cath lab not ready, and sometimes occasionally coordination across services may fall apart. However, these barriers are explored and addressed in sequential PDSA cycles, and we keep on improving and making systems more efficient. We've had our eCPR started in Qatar shortly before the COVID pandemic, and there was a hold on that, as in many other centers, and then it was started after 2023 again. In the last 2 years, in 2024, we had a total of 33 eCPR patients. 8 of them survived to hospital discharge, which is around 25%, comparable to international numbers, which falls between 25 and 35%. Our take-home messages from today is that eCPR, while being an advanced rescue technology, in practice, it succeeds or fails as a system and not as a technology. The strongest outcomes come from teams that know exactly who to activate, where to go, and how to get to flow fast. Qatar has rare advantages, including the compact geography, centralized healthcare system, well-integrated ambulance service, and one digital ecosystem. We have begun our centralized protocolized transport-first eCPR system to a cardiac arrest center with early field activation and parallel in-hospital preparation. And in the future, we may plan to expand to an advanced pre-hospital options if the volume, training, and time shows persistent benefit. And this includes the mentioned on-field cannulation and an ECMO vehicle. And with that, I'd like to thank everyone again for inviting me, and I'm happy to take any questions. Thank you very much.
Thank you very much, Nader, for this great presentation. We'll move to the question and answer sessions, and I see the first question come from Brazil, from our friend Fernando. And his question is for Marlies. The question is whether you will recommend any kinds of prophylactic antibiotic therapy for immunosuppressed patient while on ECMO.
The literature is very unclear about that. We do use daptomycin, especially initially. Most of our patients are transfers from other ICUs, and a lot of them are already colonized when they arrive, often with multiple organisms and quite resistant organisms. We see a lot of CREs as well. So we do use daptomycin, although it's, as I say, there's no specific literature to support this.
Fantastic. Thank you very much, Marlies. Since I have another question for you, because HIV is a unique population, and the team, we look to all the generic, criteria for exclusion and exclusion criteria, like weight, BMI, breast score, and other. From HIV perspective and AIDS, what would be, from your experience, selection thing that we need to carefully tailor for this group of patients? What would be the thing that's specific for them, that like, oh, I will worry to put this patient in ECMO, or what, no boundary, we should go. What would be the unique thing for this group of patients from prognostication and selection perspective?
So I think the most important thing is that you have to look for AIDS defining criteria, end stage AIDS instead of just the HIV positive patient, because we take most of these patients, but we've seen a couple of patients with severe GIT problems on ECMO, and it turned out to have malignancies and CMV activations. We had one patient, she came to us HIV positive, Candida parapsilosis, fungemia, put her on ECMO. She did well. Every time we start anticoagulation, massive GIT bleed due to a CMV enteritis, which is actually not treatable, because unless you go and take out all her bowel, so we treated her for 3 weeks on ECMO, managed to get her off ECMO, and 3 months later she still died from her AIDS defining illnesses. So I think we're not good enough at looking at the patients that's end stage, where salvage therapy with ECMO is not going to make a difference to long-term outcome. Yes, we do get them through the initial ECMO run, but in terms of resource constraints, we should be very careful with our patient selection. Overall, the patients with PJP that we see is younger patients, often single organ failure, often overweight, women more than men, often in their late 30s, early 40s. So these patients do very, very well. But as I say, we get sometimes caught out by the late stage age defining criteria.
Is Kaposi sarcoma obviously is probably one of the will be contraindication. What would you say?
Yes. For us now, we've done a couple of patients where we only found out that the patient had Kaposi once the patient was on the ECMO already, and none of them survived to hospital discharge. So I think that should be one of the exclusion criteria.
Excellent. Thank you very much, Dr. Marlies. Since I have a question for Dr. Arban, it would be about what do you think from the future of the CO2 removal? ECMO has been evolving significantly. Echo, comparing now non-invasive ventilation versus intubation to CO2 removal devices. If there is any room to expand further on that regard, Dr. Arban?
Yes, I think the CO2 removal is going to be a very good, important part in our life in next decade. But we have to accept that in ARDS with low tidal volume strategies, where actually all the papers are probably 90% publications are around that for the use of ECOR, is not given promising results. Probably either they have landed up in ECMO or probably they have failed. But the important indication, which is coming in a bigger way, and in our practice, we have seen these end stage COPDs with CO2 retainers. They are doing fantastic. So if you can extrapolate this ECOR strategies to them for the COPDs, for the CO2 retainers, those patients are doing better, and they are actually coming within 2 to 3 days without ventilator, or probably they're getting off ventilator on ECOR easily. So probably this indication is going to come in a bigger way, and some cases of asthma and all these things where CO2 is the problem. If you want to give this ECOR with the CRRT, which is coming again through different this Prisma lung and all these things. I don't know how they are going to do, because the flow in this kind of patients are not good. How much carbon dioxide will be taken out by 100 ml, 120 ml, 130 ml flow, I don't know. Whenever we have given lesser than flow of 250, 300, the ECOR failed. And you have to choose the patient, because in MODS, in multi-organ failure, with other things, the ECOR results are not good. So if you choose these patients for COPDs with end-stage COPD with CO2 removals, probably they are going to give you fantastic results.
Amazing. How about, now we've seen how dialysis developed over the years. When dialysis started, everyone was like, oh, this is, it's dangerous and so on. Now everyone getting hemodialysis and CRRT. And there is a group of patients who have a chronic CO2 retention, and we keep giving the NIV and so on. And we've seen the development of LVAD, for instance, and other devices that people can go home with it. There is for echoes, CO2, because there is a chronic CO2 retention problem in certain chronic COPD patients. Would there any be future for home devices that can be less invasive, percutaneous, that can remove the CO2 and be connected? What do you think of that?
Yeah, that's a fantastic idea, but I don't know whether somebody is trying for that or not. That is a fantastic idea, because these patients are kept on coming to the hospital, and they're continuing on this BiPAP and ventilator intermittently, and this right heart failure associated, they're debilitated, and probably some patients will also waiting for the lung transplant. They also get benefited because of this. You are right, all this, but I till now I don't know any kind of this kind of machines or the implantable CO2 removal devices, whether available or not.
Yeah, maybe area for innovation. We'll see.
Yeah,
Thank
yeah,
you very
yeah.
much, Carbon. Great talk. Dr. Andira, it's your talk is it's very unique. You went through a really different indication with a good outcome. Obviously, not everyone will have a good outcome. However, the thing that caught me was the dengue group of patients, and there's many people around the world that might not have that experience in managing these patients. I had one patient in my entire career who didn't really do well for hemorrhagic complication, and wanted to see if you can shed a bit of light on that group of patients, if you don't mind.
Sure. I'm speaking on behalf of all my colleagues also who have managed a lot of dengue patients on ECMO. So the indications for ECMO in dengue. So dengue, as we all know, is fluid responsive, and you just have to give, there's no specific treatment. You have to just support the organs, give a lot of fluids. Now, dengue myocarditis, so isolated dengue myocarditis can present with cardiogenic shock, and that's where you may need VA ECMO support for the myocardial recovery. And I know colleagues across India have managed. Very rarely, if the child goes into early multi-organ dysfunction, despite, because sometimes there's late referral, despite low platelets, ECMO can still be offered to these children along with fluids, knowing very well they're going to have a lot of capillary leak in the first 48 hours because of the ECMO, because of the dengue. But rather than losing hope, you can initiate anticoagulation-free ECMO for these children. And we all know that dengue patients bleed because of shock. It's not the platelet count. So if you have shock, they're going to bleed regardless of the platelet count. And so offering ECMO to them actually improves your oxygen delivery to your tissues and gets the liver better, gets your shock better. And of course, you'll have to keep on top of fluids, give the albumin, etc., for the capillary leak, which is going to last for the first 3 days. So these are the two indications, both VA, you will have to use VA ECMO, or if there's a secondary infection because of the dengue, then of course for the ARDS, you would use VV ECMO. But generally for dengue, it is VA ECMO for the shock or for the isolated myocarditis.
Excellent. Thank you. Thank you very much. Dr. Nader, just one question. It's really great. We work together to build this national ECPR for the country, and you clearly share that Qatar is a small country. Is easier to do that. Obviously, in a larger country, it might be very difficult. So I wanted to ask you, in terms of cannulation on site or on a vehicle that is fully integrated with fluoroscopy and everything, versus transport to the center and doing, what would be the pros and cons on that? And what do you think would be the best strategy, especially if it's a small area that is not very large? What do you think?
So I think it's as you know, it's a systems issue, and it's whatever works for the system where we can, like, the main issue is to keep the low flow time less than 60 minutes or 50 minutes if possible. So if it's within a small geographic area like 30 kilometers, and we have a highly selective inclusion and exclusion criteria with good communication between the command center and the team on site with high quality CPR en route to the hospital, then I don't think in a geographically small country, I don't think the priority is to have a mobile ECMO vehicle. But I would think that it's something that we may need to consider for patients who are out of a certain perimeter, perhaps 30 or 40 kilometers, where transportation would take longer time. And in this case, it may have some merit. So I guess the end point is we have to start flow before 60 or 50 minutes. And if this is not achieved due to patients stranded or difficult to extricate, sometimes we have people who with difficult extrication, this will prolong the low flow time. Then perhaps having that capability, perhaps a hybrid system where an ECMO vehicle is available with a priority of cannulating the patient on site, like in the hospital. But if it's not feasible, an hybrid system or an ECMO vehicle that is accompanying the ambulance can stop and start cannulating at a certain cut-off point where we know that we will not make it to the hospital on time. But I think it needs refinement and continuous experimentation and improvement of the cycles.
Amazing. And can you shed the light on, you mentioned a patient that difficult to extract. Can you just give us a bit of who are these group of patients that difficult to extract to bring them to the ECMO center?
So, people who are, for example, in high-rise buildings, sometimes where there's like power failures, difficulty in moving them, or patients who might be found in odd areas, for example, Recently, we had someone in a swimming pool in a high-rise building that was on basically on the roof of that building, and it took a long time to bring the patient down. Perhaps these patients with anticipated prolonged extrication time, national disasters, events where the roads may not be it may not be easy to arrive to the hospital on time. I think with these situations, it's important. House fires. We had few events where the fires and difficulty in extricating patients. So I would think these situations would necessitate like on-site cannulation and won't wait long to arrive at the hospital.
Amazing. Thank you very much, all the panel, Dr. Arban, Dr. Andira, Dr. Marlies, and Dr. Nader. Pleasure to have you all. I think we finished our first session on time, and we will move to the next session. So we'll ask the new speakers, Dr. Brahimi, Dr. Anada, Dr. Vivek Gupta, and Dr. Ajana to get ready for the next session. And I think we are 3 minutes ahead of time, which is very good. So we have time. And we will start with Dr. Brahimi from Morocco. It's amazing to see how is the the ECMO science and technology is spreading across our chapter, and we still need much, much more. The team in Morocco started recently, and they joined also as well. Dr. Brahimi is the Chief of Intensive Care and Emergency at Mohammed VI Hospital, University Center, anesthesiologist intensivist from Agadir, Morocco, who's been very active in building capacity and ECMO education in the region. And he will walk us through, New Horizon, really expanding ECMO access across Africa. Started in Morocco, hopefully go to Northern Africa and then Middle Africa and much more. Dr. Brahimi, the floor is yours. You can start at any time. Thank you.
Thank you, Dr. Ibrahim Hassan. I don't look at my presentation, Dr. Ibrahim Hassan, because I sent for you my presentation. Please, Ibrahim.
You send me your talk on
Yes.
absolutely,
Thank you.
certainly. Apology for that. I will share my screen
If
shortly.
it's easier for you, you can send it to Christine or I as well. Just let us know.
Should I send it to you, Peter?
Either way, because I know you're on your phone, it seems like whatever's easiest for you.
Okay, I will just try to open it in my PowerPoint.
Thank you.
Let's see. Okay, and I will share my screen. 1 second. Sorry for this technical glitch. Share screen. Share screen. Start broadcast. And then I will go to the presentation. Okay,
Yes.
can you see my talk? Okay.
Yes. Thank you. I want to speak in French, please.
Sure.
But I don't have man of my presentation is possible. Thank you. Anyway, thank you, Dr. Hassan. Chers collègues, bonsoir et bonjour à tous selon l'endroit où vous vous trouvez dans le monde. Je suis le professeur Ibrahim Husni de l'Université Ibn Zor d'Agadir au Maroc et c'est un immense privilège de participer à ce moment, à ce sommet mondial de 24 heures, un événement unique dédié à l'héritage d'un homme qui a transformé la médecine intensive, le professeur Robert Bartlett. Mon intervention s'intitule New Horizon Expanded ECMO Access Across Africa et je souhaite aujourd'hui partager avec vous la réalité, les défis, mais surtout l'espoir d'un continent en mouvement. Please, presentation. Donc, Seymour, Dr. Bartlett dit Machine don't save life, people do. Seymour résume parfaitement la philosophie du professeur Bartlett, car au-delà de la technologie, c'est la vision, la persévérance et l'humanisme d'un homme qui ont rendu l'ECMO possible. Rappelons les jalons essentiels de ce parcours extraordinaire. En 1965, il débute ses recherches sur l'ECMO. 1971, un patient adulte servi pour la première fois grâce à cette technologie. Un cas publié dans le New England Journal of Medicine. 1975, il sauve Babé Esperanza, le premier nouveau-né traité par ECMO, un moment fondateur. En 1989, il fonde l'ILSO Extracorporeal Life Support Organization, créant ainsi un réseau mondial d'excellence. Son héritage sont plus de 200 000 vies sauvées, 750 centres dans 66 pays. Le professeur Bartlett nous a quittés en 2025, mais sa vision continue de guider chacun d'entre nous. Ce sommet est notre manière de lui dire merci, professeur, votre flamme ne s'éteindra jamais. Regardons maintenant l'état de l'ECMO dans le monde. Les chiffres sont impressionnants. Plus de 200 000 vies sauvées, 750 centres d'ILSO certifiés dans 66 pays. La croissance de l'ECMO adulte est particulièrement frappante en 2009. On comptait 851 cas. En 2021, ces chiffres ont atteint près de 18 000 cas. C'est une multiplication par 20 en 12 ans, accélérée par la pandémie Covid, qui a démontré de manière dramatique l'importance vitale de cette technologie. Mais derrière cette réussite mondiale se cache une réalité troublante. Cette croissance est profondément inégale et c'est là que l'Afrique entre en scène. La réalité de notre continent, l'Afrique, avec 1,4 milliard d'habitants, a un accès quasi nul à l'ECMO. Moins de 5 centres sont réellement actifs sur l'ensemble du continent. Les chiffres sont saisissants. La mortalité néonatale atteint 27 pour 1000 naissances vivantes. Plus de 80% des patients en détresse respiratoire sévère décident faute de l'accès à l'ECMO. Quand on compare les régions, l'Amérique du Nord compte environ 300 centres, l'Europe 200, l'Asie-Pacifique 150 et l'Afrique moins de 5. Ce contraste est inacceptable. Chaque jour, des patients africains meurent de pathologies que l'ECMO pourrait traiter. Ce n'est pas un problème de compétence, c'est un problème d'accès, de moyens et de volonté politique. Pour comprendre cette situation, il faut analyser les obstacles auxquels... Diapo suivante, s'il te plaît. Please. Donc, pour comprendre cette situation, il faut analyser les obstacles auxquels nous faisons. Ils sont multiples et interconnectés. Le coût prohibitif, un seul circuit d'ECMO coûte entre 2 000 et 10 000 dollars dans des pays où le budget de santé sont extrêmement limités. C'est un luxe inacceptable, inaccessible. L'infrastructure, le manque de lits de réanimation, l'absence d'équipements biomédicaux adaptés, la pénurie de personnel qualifié. L'ECMO exige une expertise pointue en réanimation, en perfusion et en soins infirmiers spécialisés. La fuite des cerveaux, nos meilleurs spécialistes partent souvent exercer dans les pays où les conditions sont meilleures. La chaîne d'approvisionnement, l'accès aux consommables, aux canules et aux membranes est un défi logistique permanent. Le transfert de l'ECMO, transférer un patient sous ECMO reste quasiment impossible dans la plupart des contextes africains. Ces défis sont considérables, mais ils ne sont pas insupportables et la preuve, c'est que des équipes africaines sont déjà en train de relever. Malgré les obstacles, un paysage écomo-africain est en train de naître. Laissez-moi vous présenter les trois piliers de cette émergence. Le Maroc est aujourd'hui le pays d'Afrique du Nord le plus avancé en matière de développement de l'ICMO, avec des initiatives dans 7 villes, Tanger, Oujda, Casablanca, Rabat, Marrakech, Agadir et Lyon. Le Maroc construit un véritable réseau national et j'y reviendrai dans la diapositive suivante. L'Égypte dispose d'un programme solide centré autour de l'Université de Caire sous le leadership de mon ami, le professeur Akram Abdelbari. L'Egyptian ECMO Working Group et le programme ECMO Expert Course forment une nouvelle génération de spécialistes. Le Kenya et l'Afrique du Sud représentent les avant-postes de l'ECMO en Afrique de l'Est, centrale et du Sud. Au Kenya, le Kenya National Hospital à Nairobi et l'hôpital Aga développent des programmes prometteurs en Afrique. Le programme ECMO à Pretoria est l'un des plus établis du continent, avec au moins 5 centres. Ces initiatives prouvent que l'ECMO en Afrique n'est pas qu'un rêve, c'est une réalité en construction. Permettez-moi de vous zoomer sur le Maroc, car notre expérience est qui est possible quand la volonté est là. Tanger en Nord abrite Tanger Sim, le premier centre de simulation ECMO en Afrique du Nord, développé en partenariat avec Cardioplus et le CHU de Bordeaux. C'est un modèle de collaboration nord-sud. À Oujda, notre équipe au CHU Mohamed VI a développé un programme actif d'ECMO veineuse pour la détresse respiratoire aiguë sévère. Nous avons publié nos résultats dans des revues indexées et nous formons des spécialistes dans le cadre de formation d'ECMO. Rabat, Casablanca, Marrakech développent également les programmes au sein de leurs CHU respectifs. Agadir est un centre émergent et Laayoune, dans nos provinces du Sud, est en phase de planification. Signe de notre ambition de couvrir l'ensemble du territoire national. Depuis 2023, nous organisons chaque année des masterclass et des formations continues. Nos collaborations internationales se renforcent. Le Maroc veut devenir un hub de formation ECMO pour toute l'Afrique francophone. Soit qu'il soit un levier pour l'Afrique. Pour porter cette transformation, nous avons un allié de taille, le SWAC ILSO. SWAC a été fondé en 2013. Il est important de souligner que le professeur Bartlett lui-même a été à l'origine de sa création. Bartlett croyait que l'ECMO devait être accessible partout, y compris dans les régions les plus défavorisées. SWAC couvre aujourd'hui 13 pays membres représentant 2,56 milliards de personnes. L'Inde compte déjà le premier centre Platinum ILSO de la région. La deuxième conférence SWAC s'est tenue à Chennai en février 2026. Notre stratégie pour l'Afrique repose sur 5 piliers. La formation, programme de simulation fellowship. L'innovation, adapter les techniques au contexte de ressources limitées. Le réseau HubSpot, connecter les centres experts aux hôpitaux régionaux. La télémédecine, mentorat à distance et support en temps réel. La partenariat, collaboration avec l'industrie, les gouvernements et les organisations internationales. Notre feuille de route ECMO Afrique 2026-2030, nous proposons un plan concret, structuré en 4 phases. 2026, l'année de sensibilisation, cartographie des besoins, établissement de partenariats stratégiques et lancement des premiers cours de simulation ECMO en Afrique, c'est l'année de la prise de conscience. 2027, formation, la mise en place du fellowship dédié, le déploiement du cours ILSO certifié et programme de mentorat dans les 7 villes marocaines et au-delà. En 2028, la mise en œuvre, lancement du centre pilote au Maroc, en Égypte et au Kenya, déploiement du modèle HubSpot et intégration au registre ILSO pour assurer la traçabilité et la qualité. 2030, c'est l'année de la Coupe du Monde au Maroc, en Espagne et en Portugal. Donc, c'est l'année de la durabilité. Notre objectif est d'atteindre plus de 15 centres actifs, de développer la recherche locale, d'assurer l'autonomie régionale et de créer un chapitre africain de l'ICMO au sein de l'ILSO. Notre ambition est claire, faire de l'Afrique un acteur reconnu de la communauté ICMO mondiale. Pour conclure, chers collègues, chers amis, ensemble, ouvrons de nouveaux horizons. L'ICMO ne connaît pas de frontières. Chaque patient en Afrique mérite cette chance de vivre. C'est notre responsabilité collective et c'est le message que je porte. Je vous lance un triple appel. Collaborons à travers le réseau soit qu'il soit. Partageons nos expériences, nos protocoles, nos expertises. Formons de Tanger au Caire, de Nairobi à Pretoria. Investissons dans le capital humain. Investissons dans les politiques de santé, dans le financement, dans les infrastructures qui rendent l'ICMO accessible à tous. Je dédie cette présentation à la mémoire du professeur Robert. Son héritage vit dans chaque circuit ICMO qui sauve une vie. C'est à nous maintenant de porter cette flamme en Afrique. Et merci de votre attention. Thank you. Thank you, Mr. Brahim.
Thank you very much, Dr. Brahimi. It's amazing. ECMO unite us. We had in English, we had in Spanish, now in French. A real pleasure, really. And please stay with us online, Dr. Brahim, for question and answer session. It's, although it's in French, but I understood pretty much everything. And, it's amazing to hear that 1.4 billion have zero access to ECMO in Africa. And it would be very interesting to hear from you a bit in the strategy for these patients going forward. Our next speaker is Dr. Nada Jassim. She's a pediatric cardiac and medical intensivist, pediatric ECMO service line leader for Riyadh Second Health Cluster, assistant professor at Al Faisal University. She's the founder of the Pediatric Respiratory ECMO Retrieval Team in the Ministry of Health in Saudi Arabia, expert in pediatric ECMO cannulation, simulation, training, and education, and have a numerous publication in the field of ECMO. It's a great pleasure to have you, Dr. Nada, really talking about tiny lungs, giant machines. Pediatric ECMO for severe respiratory failure. Dr. Nada, the floor is yours. Thank you.
Thanks so much for this great invitation. Is my voice clear?
Yes, it is.
Yep.
Yes,
Perfect.
yes.
Although I'm not able to show my slides yet, and trial and backup slides coming to you on the group.
Apology. I will. You send it to me, Nada. I will.
Yes, if it's not showing on my screen. But
Oh, no worries.
It
No
is
worries.
showing. We see it.
okay.
Oh, we see it. We see it. Yep. All good.
Perfect. And due to the configuration of my computer, I'll just skip opening the camera if you apologize me. Thanks so much for this invitation. I'll be speaking about the tiny lungs with giant machines and pediatric ECMO experience for severe respiratory failure. As ECMO served to help many patients and increase the survival in pediatric ARDS in neonates and children worldwide, still there are hiccups with pandemics and endemics that could happen with increased mortality for those who are refractory to maximum support. And despite the ongoing development worldwide since the beginning of this great technology, still the number of neonates and pediatrics ECMO are not that much in comparison to the adult cases. Although the first successful case was started with a neonate, but I believe many intensivists and neonatologists and pediatric intensivists are shy of using it with many challenges that we had tackled through multiple sessions and interactive webinars and talks in the conferences. Establishing ECMO in a unit is not an easy job, yet the also have served as a great source and organization of support with a provided base to launch the program, and amazing networking and global collaboration with unlimited support worldwide, which I personally have encountered in my case. So we started in Saudi and in Riyadh at King Fahd Medical City with zero nurse who knows what is ECMO, zero ECMO machines serving pediatrics and neonates both. And yet many centers in our region in this SWAC had expanded programs to serve those populations, although, as I mentioned, generally speaking, the centers in SWAC, in comparison to the other regions, are in a development phase to expand further, similar to the international, but much less again in pediatrics. So as ECMO provided organ support for while allowing the lung rest and recovery, having other guidelines and in PALIC in our situation with pediatric ARDS supportive the use of ECMO had also a gap where we need to match those guidelines where everybody is following with an ECMO guidelines for the pediatrics that would support multiple and unlimited etiologies for refractory ARDS that would encountered in pediatrics. So to increase the awareness about those guidelines and the indications into having a trigger to call and a trigger to consult the ECMO team and the experts, we found it the most feasible part to convince people that those patients, if are early called and early referred to an ECMologist, may have better outcome and better chances of extra support, extracorporeal support in this situation. So in one of the endemics that happened is 2025, we encountered several cases of influenza with misbehavior across children between 2 to 10 years old. Those patients were having severe pneumonia, specifically with influenza A and few influenza B, and they were associated with those patients presented with acute kidney injury and acute liver injury and high inflammatory markers, with referral to subspecialties, rheumatologists and infectious disease services. They were having pictures of macrophage activation syndrome and HLH as well, and in one case MISC associated with influenza A, where we were about to report those cases. Like we had 12 cases have been retrieved between November to February, November 2024 until February 2025, have been retrieved from all over the places in Saudi Arabia who presented with refractory hypoxemia and started to have progressive multiple acute inflammatory syndrome in affecting many organs. Mobile pediatric ECMO team at that time was already 5 years old, with expansion and great steps moving forward to being serving even neonates with the ground transportation though, but pediatrics from 5 kilos and above, served those patients and helped to get a survival of 100% intact survival and no major complications encountered. With the support of subspecialties treating those patients with IVIG pulse steroid in parallel to the ECMO, which I believe the oxygenator have helped to clear those patients as well, and some of the extracorporeal technologies of inflammatory markers removal and so on had improved their survival, and few patients also with early referral, we were in a follow-up until they improved and they were out of the ECMO criteria. So the pediatric ECMO triggers have been selected to trigger people to call because of the map of the map of the country and the transportation timing, up to 3 hours by flight to go north, and up to 3 hours, 4 hours ground transportation to go through 300 kilometers to the east in some region that doesn't have airports. We were having selective triggers to be able to reach patients on time, like whenever saturation is not handled well by the patient in more than 90% on 100% of IO2, certain hypercapnic acidosis, not really supportive, the PALIC guidelines of saying pH 7.25 and above, then we would select this patient for ECMO, but we were in less than that, 7.28 pH and CO2. Whenever it is 70s to 80s, not waiting for 80s and 90s or 100s, which is the usual comfort zone for many pediatric intensivists who are not calling for ECMO unless late. And also we got some challenges of the duration, because calling after 7 days, we found the outcome and the length of being on ECMO is not as great as in less than 7 days, as supported by the also guidelines as well. We had the committee discussion. We had multiple people. We started as 2 people who are doing the retrievals, and now getting up to 7 intensivists doing retrieval with hands-on cannulation by themselves, and getting the surgeons on board gradually because of some of the challenges related to their engagement and involvement in the region as well. So moving forward, multidisciplinary team had been trained with specialized training, also going through what is available in the worldwide and what we have on our region. With resources limited in some situation, we had to build our own simulation-based education and recognized, and we are moving into recognized also endorsement as well. Standardized protocol and guidelines that are available for best practice are available, but not everything could fit on some of the situations. So we had to tweak and tackle some of these guidelines as well, with continuous and consistent quality improvement toward international recognition and a global connection that absolutely had unlimited support from colleagues and from experts worldwide, from whom we are whom they are great friends from all over the world in the ECMO community as well. Expansion of this impact has been really rewarding to replicate this idea in other centers and in other regions, including having many pediatric ECMO courses specifically to the pediatrics, many webinars and education with collaboration of our international colleagues who are invited to help out and talk about their experience and encourage early referral and deployment, as well as mobile retrieval program establishment and development with better transport capabilities gradually as well. The regional ECMO network and the global collaboration was aligned all over the period with their great and encouraged ideas for moving forward with next generations from practitioners and leaders to have better training all over the places. These are some of the examples of what we had built on, from videos to the families to the practitioner criterias. We have the online tele ICUs utilization of the Ministry of Health program and also build our own ECMO nursing competency with alignments of what is present worldwide as well. So tiny links are giant machines, a legacy of hope, and I hope to have more than one retrieval program in the region that would serve all patients all over the place within an ideal timing, not only for respiratory, but also for cardiac cases and for eCPR, where we had to go through this exercise for some complicated cases successfully as well. So ECMO represents innovation and teamwork with courage in critical care. Thanks to Professor Bartlett for a legacy that continues to save children worldwide. Thank you.
Thank you very much, Dr. Anada. Really a great presentation, and it's beautiful, really, to see again the legacy of Professor Bartlett across all the continent, and to continue Morocco, starting Africa, and the great transport network that the team in Saudi is building. Please stay with us for question and answer. We will move to the next speaker, Dr. Vivek Gupta. Vivek is the chairman of Research and Ethics Committee at SWAC also. He's a cardiac anesthesia intensive care ECMO physician, work in Ludhiana, where they hosted actually the SWAC also in India before Abu Dhabi. He's also past president of ECMO Society of India, awarded fellowship of Indian College of Critical Care Medicine, and many award expert in ECMO field. And he's going to give us a talk about registry-driven ECMO, using data to improve survival. Vivek, the floor is yours. Thank you.
Thank you, Ibrahim, for the nice introduction, and thanks for the opportunity to speak on this forum. So what everything we are discussing today is basically regarding Professor Bartlett, because you can't imagine 275,000 of ECMO runs, 600 centers, AI integrations, and the global registry. Actually, the traces of this, its origin, started with a single physician who actually refused to accept that a 2-year-old child cannot be saved in 1972. And look at this, where we are exactly today. So, why registry is important? Because there are evidence gaps. We can't do RCT in the ECMO because we are doing these procedures during as a last resort in such a critically ill patient. It helps us to drive a protocol, harmonize the quality benchmark. In fact, centers can learn from each other. Low volume center can get benefited, and we can get the global insight. And definitely it is going to impact the survival. Just an example, that my center has a survival of 58%, but the top ELSO center has a 68%, while national average is 52%. And low volume center had the poor survival. So I can compare myself and I can review this, that how I can improve the outcome in our centers. We have definite evidences that the standardization of anticoagulation, circuit management, especially the adoption shift from the silicon oxygenator to the PMP oxygenators, winning strategies which has helped us for the looking at the best time to extubate our patient, are selecting patients on the basis of various patients' pre-ECMO parameters. And we know that we have evidence for it. That in 2009, that gives us a significant impact on our practices, and actually that was a turning point that ECMO, rather than salvage therapy, we started adopting it for the ARDS patients. And the biggest example is the COVID pandemic. If we would not have the registry, probably we could not have rapidly collect the data and discuss these things, so that across the world, we were able to address these several issues simultaneously. So it has helped us for more than 1,200 publications, 47 machine learning models, and 8 landmarks guidelines. So this This was not possible without the registry, but there are challenges. Because we know that every time we are doing a manual entry, and that actually a biggest hindrance, because you have to enter the data in the hospital EMR and then you have to do the manual entry, and it does not give a real-time feedback. So it takes very long time, and probably this is one of the big reasons. Moreover, other challenges, missing outcomes. So many times this has a high impact. Inconsistent definition of the several complications are because of the different definitions. There are some selection bias because high volume centers, they participate more, and those who are low volume centers, they might not participate that much to the data entry. Or there is a temporal lag that when you are entering the data after 3 months or 2 months, probably you can't recall so many things. So the manual data entry, which definitely is a big challenge during this, and other confounding and selection bias, like observational data, cannot fully adjust for indication bias without sophisticated propensity modeling. Or there is a missing data, multi-level modeling, and temporal trend and composite outcome definition. So what are the challenges? It's different in the different part of the world, and especially in our South SWAC also region. Infrastructure deficits, there is a language barrier. Then there are some regulatory complexity, that ethical issues that you can't share data, you need to approval from so many regulatory authorities. Financial barrier, you don't, because the low-income countries, they have the low budgets and they cannot put a data manager to do all these entries. And then institutional trust. So there are challenges that who should be in the publications, those who are contributing centers should be there, regulatory authorities issues, and patient privacy issues. So these are several challenges, and how to improve this worldwide, because we have to overcome the challenge and we have to manage these data to be entered to get the best outcomes, so that we can develop a best strategy to manage the situation. So the best way is, if the data is integrated with the EMR, no duplication of data, no manual entry. AI assisted entry. If there are mobile apps, probably that can help point of care addition of the data. Cloud-based platform that can really help, so that there is no issues related with the patient identification data is shared, or the complete data is being shared. Automated validation, that is going to help us immediately we understand that the data has not been entered in the correct way. So these are some important points. Then we have to standardize the complication definition, so that across the data, the registry data, it is uniform. International coding system, probably that can be helpful, and the annual meeting to review the harmonization, that how we can harmonize the data, probably can be very helpful. Definitely also has done so many things to improve the data collection and registry. These various centers are being given on the basis of the data quality. But this can be added with the access privileges, that those who are entering data probably can have the early access to the data. Financial support to the low and middle income countries, and education and training, which already the SWAC region is actually significantly participating. So basically the focus should be on the infrastructures, so that probably a WHO or any other international body can be helpful when it can integrate with the ELSO, because that will add the ECMO as a critical procedure. If WHO has, because it has its own wide acceptance across the world, then probably it can be more helpful. The other things with AI powered addition of the AI that will alert us the real-time complication, are augmented intelligent dashboard, which can be helpful for getting immediate results, so that a person can be alerted. A live data can be much more useful as compared to the data which we are getting at the latter time. We know that so far we have more than 2,000 publications, and the highest publication was in 2022. And every time there is a structured model with the ELSO that they are getting a proposal for research are at almost 52% of the annual approval rate. And these are the landmark trials we all know that has changed the ECMO practice across the world. The recent one is the ELSO registry, that international report in 2022, where 1 lakh survivors were included in those studies. That speaks the volume, and that makes us understand that how important the data is to collect the data for research purpose and for looking at the outcome. Not only this, the guidelines, neonatal and pediatric respiratory guidelines, adult respiratory guidelines, adult cardiac guidelines, and ECMO CPR guidelines. This guides us that what should be the best strategy to manage these patients. And this is only possible with the data entered in the registry. Different scoring system, which help us to predict that how we can tell the patient's attendant that what can be the survival, or we can understand that what is the survival possibility. Then outcome metrics, process metrics, and complication metrics. That survival to discharge, calculating time to candidate for the ECMO CPR, our circuit change rate. These all contributes to improve the patient details in the registry. These all contribute that how it is compared from one center to the other center, so we can improve our process quality metrics. But there are certain unanswered questions that what is the long-term outcome, especially in terms of neurological outcome. Probably we need to work more on this. Optimal anticoagulation, though a lot of work has been done, but still we need ECMO anticoagulation-free circuit. Probably that will be the most safe ECMO run, and definitely weaning strategy and health economics. So if we look at the practices across the different regions, we know that by looking at the registry, we understand that on which side the VA ECMO is more or VV ECMO is more. Similarly, we can look at the survival data in the different zones, and the monitoring practices are targeting for the how we are monitoring the heparin. All these can be evaluated. Even the difference variation of the practice, like in the certain region, the percutaneous cannulation is preferred, or surgical cannulation is preferred, or which oxygenator is being used, or certain different kind of pumps are used. All these can be done through the help of registry. And what is more important to remember, every run entered, every life is counted. Here comes the role of clinician who are entering the data, the center who are investing on the data manager, societies like ELSO who are participating in the training to the various centers and looking at various centers to enter the data. Industry partners, they are helping us, are reaching to the different zone of the world and helping people to enter the data in the registry, and definitely support from the government, which makes it essential to enter the data, provide infrastructure, and the mission up to 2030 should be every ECMO-capable hospital on Earth contributing to a single unified global registry, which will help us to understand the complications, our practices better, what we have learned so far in the registry. Thank you very much for the opportunity. And
Thank you very much. Thank you very much, Dr. Gupta, for this great talk on the registry. Please stay with us. We will have a question answer session a bit shortly. Next speaker is Dr. Jana Asi, who is going to talk to us about ECMO and fragile health system, keeping patients alive when systems are not. Dr. Jana is cardiac intensivist who is the founder of the ECMO program in Lebanon. I had the pleasure to work with her for many, many years, and she's a part of SWAC also, and you're also at the same time secretary for the SWAC also, and one of the real active member who kept us in check in many way, and also and obviously in education and training. She's an expert in education and help developing many courses for pediatrics, invited speaker across all the continents for pediatric ECMO and cardiac ECMO in particular. Dr. Ajana, welcome on board, and the floor is yours. Please go ahead.
Hi, sorry, just a small technical problem. We'll be right here with you. So thank you for the introduction. I'm very honored to be here today with you. So I'm not going to talk a lot about actual ECMO because we all know that it's one of the most advanced forms of life support we can provide. It requires specialized equipment, highly trained teams, and strong infrastructure. But for this reason, ECMO is often considered something that only large, well-resourced centers can offer. But critically ill patients exist everywhere, including in healthcare systems that are fragile or unstable. And today, I just want to share with you the experience of developing an ECMO program in Lebanon and how mentorship and global collaboration made it possible. So fragile healthcare systems are characterized by instability, economic pressures, limited infrastructure, workforce shortages, and unpredictable supply chain. In such environments, introducing a complex therapy like ECMO may appear unrealistic. Yet the need for advanced life support does not disappear simply because the system is fragile. So in 2016, we began building a pediatric and adult ECMO program in Lebanon, the only one and the first one in the country. The healthcare system was already under a lot of strain due to regional instability and the refugee crisis again and again. So training opportunities were limited and maintaining specialized teams was challenging. Despite these obstacles, critically ill patients still required advanced support. In fragile systems, programs must grow gradually. So we started with a small multidisciplinary team. We limited the indications and we had strict protocols. But this allowed us to develop the program safely while adapting it to the realities of our environments. So resource limitations really required creativity and adaptability. We had to redesign workflows, equipment was sometimes repurposed, and the team relied really heavily on continuous bedside vigilance. What compensated for limited resources was a strong commitment for the team. So when we talk about infrastructure, we imagine dedicated ECMO consoles, oxygenator, cannulas, reliable power, and emergency backup systems. But here are really the ideal equipment and setup, but in reality, things look very different in many hospitals. So sometimes step 1 is just finding the pump, step 2 is finding electricity, and step 3 is realizing that step 1 and step 2 may not happen at the same time. And often, this is what happens in many centers, but it doesn't stop us. It just pushes us to innovate and to adapt. So yes, guidelines are there, and guidelines will tell us what to have, but reality will teach us how to make it work safely, smartly, and creatively. In our region, starting an ECMO meant working with what we had, not what we wished for. So starting ECMO really, especially the first mobile ECMO transfer, we didn't have an ECMO transport system. So when we had this first case, we had to send one ambulance with the patient and circuit and one physician, but another car was filled of oxygen cylinder. It wasn't glamorous, but it worked. And that was what innovation looks like when you're building something from scratch. So innovation is not really about having everything. It's about making the best of what you have. In the absence of dedicated ECMO cannula, the team adapted with the available cardiopulmonary bypass cannula. So there was a tight collaboration between perfusionist and surgeon to ensure safe insertion and flow optimization despite equipment limitation. Each case became a lesson in problem solving. Anticoagulation is one of the most challenging aspects of ECMO, even in high-resource centers. Without access to advanced monitoring, we relied on structured teamwork. So nurses charted with color codes, perfusionists tracked trends, and decisions were made collaboratively. It worked not because of the technology, but because of communication, consistency, and shared responsibility. In fragile health system, the most important resource is not technology, it's people. Building this program required strong teamwork and a culture of shared responsibility. Nurses, perfusionists, physicians, and trainees all played an active role, learning continuously and supporting each other. These moments of teaching, discussion, and collaboration helped build a strong team culture. Ultimately, that commitment to learning together and prioritizing patient safety became the foundation that allowed the program to grow despite limited resources. A critical factor in the development of our program was mentorship. During the development of the ECMO program, we were fortunate to receive mentorship from Dr. Bartlett. There were several phone calls and discussions with him while we were designing the program. His advice helped guide many of the early decisions, from defining the scope of the program to ensuring that safety and training remained central priorities. So Dr. Bartlett provided invaluable guidance and encouragement during the early development of the program. In December 2017, Dr. Bartlett visited Lebanon. During this visit, he spent an entire day in scientific discussions with physicians and members of the ECMO team, sharing his experience and insights. He also met with hospital leadership and key stakeholders, helping them understand the importance and potential impact of the program. His presence reinforced the credibility of the initiative and provided tremendous encouragement to the entire team. His presence also inspires and strengthens the program. So beyond the scientific discussion, his visit was also a powerful symbol of mentorship and international collaboration in a region facing many challenges. The global community, through Dr. Bartlett, continuous support, and through ELSO, provided essential support. So through shared knowledge, training opportunities, and collaboration, this network helped emerging programs and emerging programs to develop safely. So this experience in Lebanon taught us that ECMO program can exist even in fragile healthcare systems, but their success depends not only on technology, it depends on people, mentorship, and global collaboration. So Dr. Bartlett mentorship has inspired ECMO programs around the world. His visit to Lebanon was not only educational, it was a powerful reminder that the ECMO community is truly global, and his legacy will continue to shape new programs and ultimately save lives. So thank you for listening. Sorry, it was a personal experience, but I really wanted to share that with you. Thank you.
Thank you very much, Dr. Ajana. It's touched us all, to see that videos and pictures that you share and the story. It's terrific. So now we move to the question answer. Please stay with us. And I think the first question is for Dr. Brahim from Morocco. And you share a very powerful slide, of 1.4 billion patient and population in Africa with very limited access to ECMO. And you, I think, share some strategy, but in French, I don't think everyone understood. Wanted to just ask you briefly is what would be the strategy to take this and make it applicable across the continent in Africa? What do you think? Dr. Brahim, you are with us?
Yes, my brother. You can please repeat question.
Yeah, my question is for strategy, to take the ECMO further in Africa, because you share a very powerful slide. I said about 1.4 billion population with very limited access to ECMO, only 5 also center. What would be the strategy going forward, do you think?
Thank you. My answer is with French.
Okay.
Donc, je vais répondre en français, cher ami Ibrahim. La stratégie que je propose, c'est la collaboration secteur public, secteur privé. Deux, la collaboration avec l'industrie, notamment l'industrie, il doit essayer de diminuer les prix du consommable. Parce que malheureusement, le prix du kit de l'ICMO Au Maroc, par exemple, il coûte aux alentours de $3 000, chose qui est énorme. Et dans d'autres pays, il peut aller jusqu'à $10 000. Donc la collaboration avec l'industrie, la collaboration secteur privé-public et la formation, surtout par exemple pour nous, le Maroc, ce que je propose, c'est la collaboration avec les pays francophones. Voilà ma proposition pour arriver à lancer l'ECMO au niveau de l'Afrique.
Thank you. I'm not sure if Dr. Jana can translate because she speaks both French, Arabic, and English.
I expected this question. So, what doctor said is that first, it's important to have a collaboration between the public sector and the private sector in Morocco, if I understood well. The second way is to have a collaboration between industry and the hospitals, because a circuit or a consumable in Morocco costs around 3,000 USD, right?
Yes.
Thank you. Thank you very much for both. My next question is for Dr. Anada. It's really great to see the development of the respiratory program, in particular the transport and retrieval, because usually for cardiac is a bit more critical. The time might be a very time critical, but for respiratory you have a bit of time. But the always question comes, in adult we train many intensivists to do the cannulation. For peds, that's always been an issue. And I know people are moving for percutaneous cannulation now. What is the feasibility to have more intensivist-led cannulation for transport and retrieval for the pediatric transport ECMO program?
Thanks so much. This is really vital and challenging area for expansion and getting people. So the courage is not enough. Simulations and cadaveric and even animal labs are not real life, and the struggle with different sizes, different cannulas available, different support in the centers where we have also a challenge to get is it a backup surgeon or a backup other intensivist? And what if things went wrong? Is there an OR in that retrieval place, or it just like you gonna do it on your own? So it need a lot of faith and really people who are having skills that is not easy to attain for further expansion just by the simulations and training, simply like in adults. Because what we did in our situation is we attended with multiple retrievals for adults. Besides the simulations and the animal labs, then we attended with our adult colleagues assisting. Then we did it on above 20 kilos with a surgeon backup, then above 15, above 10 kilos. So we went gradual, as Dr. Jenna have explained, that within our resources and the structure, we were very careful in our steps at the same time, trying to get consistent trust and attain skills to go on our own far away, that it took us almost 3 years to be abroad with 2 intensivists without surgeon and even above 10 kilos. So in short, having the ongoing simulations and the animal labs is certainly helpful. Having observation and assisting in the procedures on real patients with up to 10 cases is not easy to get as numbers in pediatrics, especially for starting smaller programs. So even cutting it down to 5, we were choosing the most skilled intensivist with least complications reported in their usual procedures, moving them through these steps and until we get them released by and we give them the privilege by the program director, and it take a bit. So we had, for instance, people who require a year, others would require up to 2 years, and still they're not confident to go on their own. So it's not the easiest, and things can go wrong always, of course.
Of course. No, it's incredible what you guys have built so far. And if there is any problem from licensing or that the Ministry of Health take care of the authorization for, because you
No.
know
Yeah, actually, for the retrieval, it's all about the privileges of the dispatched team from their own center. So all the privileges comes through the ECMO committee, where we built and we put guidelines and also released certain criteria for cannulating intensivist on what he should attain and what he should have before dispatching him in transport or touching even patients. So certainly they have to have privileges.
Incredible. Thank you very much, Dr. Anada. For Dr. Vivek, again, it's one of the biggest challenge for the data is, we do a lot of manual data collection, require a lot of manpower. Is not easy. The registry, to maintain a proper registry data, especially with also there is a lot of data, and it's not all the centers are able to do that seamlessly. And what do you think of AI driven model for data optimization, and what would be other way to sort this problem and make it consistently and easier?
See, a very valid question and right question in the current scenario. Because if I look at the SWAC region, most of the data are manual, or even we do not enter it completely because of the lack of resources, lack of staff, so many issues that we know that these are the challenges. But still, I believe that integrating AI, probably, for example, it's simple to conversion of speech to text and standardizing, converting it to a standardized format, probably can be a great help, because that will allow any clinician or any perfusionist or anybody who is the lead for the ECMO program can enter the data in a very short span of time. And it should, because if we go for using a AI model, it will help us to do it with a mobile. It does not require a big data entry or typing it, which can be a big challenge for the clinician. So probably adding AI can be maybe a great help to enter the data, and especially for those regions where still we are doing a manual paperwork. We do not have the complete EMR system in our own hospital itself. So definitely, yes, adding AI is going to help us in a significant way. But yes, we need to develop a model, because again, the AI will have a challenge. It might be a language barrier, because you have to have a multilingual one. Or we can have accent issues also, which are probably a noise reduction. There's so many things to be worked actually before we implement the AI model for adding the data. But definitely, yes, in the current scenario, it will be of a great help.
Amazing. Thank you very much, Dr. Vivek. And my last question for Dr. Jana. You pretty much went through all the challenges and difficulties and resource limited, and you explain why. And but there is one part you didn't mention, and I witnessed that firsthand. Seeing a Dr. Ajana at the bedside, taking care of a very sick patient. And she stayed 2 weeks in the hospital, slept in the hospital, taking care of that patient. So it takes a commitment and leadership, not only everything you mentioned. And I wanted to ask you what you will say advising a new member who is starting an ECMO program in a very resource limited condition, with everyone will tell them that it's difficult, you should not do it. What would be your advice, and how to take this wisely and make it work as you have done marvelously for AUB team in Lebanon?
Thank you for the question. So I think there are two important things. The first one is really collaborating and networking. So do not do it alone. Do not have a single center working alone. Just choose other center in the country or the region or internationally. And it's very easy to do it through ELSO. So really, this is a key thing to do when starting an ECMO program in in such settings. The second thing is sometimes you have to accept the fact that you cannot do it by the textbook or by the guidelines. You have to accept that guidelines are there to guide us, but then you have to adapt it to the environment, to the local resources you have, again, without taking any risk when it comes to patient safety or compromise any patient safety while doing this.
Thank you very much, and it was really great to see the pictures of Dr. Bartlett in Lebanon. I'm sure it was an amazing meeting there. So with that, we conclude our second session. I think we are back on the schedule, and we will go to our next speakers group. We have 4 additional speakers. I wanted to thank our previous speaker, Dr. Brahimi, Dr. Anada, Dr. Vivek, Dr. Jana for a fantastic contribution. And every one of them had issue with the timing, but again, people came together, and that's the beauty of this really conference. So I wanted to welcome now Dr. Ahmed Labib, Dr. Akram, Dr. Grace, and Dr. Vivek. And I will introduce first Dr. Ahmed Labib, who is a great friend and colleague of mine, ECMO on Wheels, a safe transport, retrieval, and mobile ECLS. Ahmed is an intensivist anesthesiologist trained in the UK and joined Qatar team. He's one of the founder of the ECMO program in Qatar and the transport lead for the country who helped building the ECMO transport and aeromedical retrieval. He's also a part of the member who authored the ELSO guideline for transport. He's actually the first author for that, has a numerous publication on ECMO. Pleasure to have you, Ahmed, to give us a talk on the ECMO on Wheels, safe transport, retrieval, and mobile ECLS. Thank you. Floor is yours.
Thank you so much, Dr. Ibrahim. It's an honor and pleasure, and I'm really grateful for the organizing committee to consider me as a speaker in this eminent and significant webinar. So for me, I just start with, is the voice clear and the video is clear, the screen sharing?
Yes,
Okay.
all is good.
So my main disclosure here, I am forever will be indebted and grateful to the ELSO Godfather. This is us in Emirates 2015, and it was an honor and pleasure to see the master and learn from him, and I will always remember and cherish those moments that we had with him. The transport in ECMO always started by him, and this is one of the very early papers that was published more than 20 years ago. Actually, it was published in 2002 in Asayo, and this is the very first experience with mobile ECMO and transportation ECMO that was led by Professor late Bartlett. And this is the outcome from this transport, and there is a lot to learn from this study, looking at how they designed the stretcher, how they put the equipment, how I would say primitive and very early developments of technology of transport and ECMO. And despite this, they managed to cover a very wide area with successful transport, and they recorded no complications. And this is, at the time, is something really remarkable. So what we learned from there is that we took this again, and we looked at this in 2019. We took in almost now 8 years, and we started looking at transport and how we learn from the experiences led by Professor Bartlett and how to make this continuously and safe and efficient. And this we started by collecting the data, and we found that we need to update the transport guidelines and add all these new elements to it, just to maintain the safety and efficiency of the system. There was a lot to be done, and the outcome is the guidelines. And again, I was honored and privileged to work and see the comments from Bob every time I send a version of this. It took us 2 years because you see the group was large, but the leadership of Professor Bartlett, or Bob as he liked to be called from his close friends, was immense, and it was remarkable, and it helped to shape this document in its current shape and form and provide a framework for safety and efficacy of mobile ECMO. So what we learn from this, and how can we improve the safety of ECMO and whatever you do to transport patients, be it an adult, a pediatric patient, or a neonate, is that you first have to understand that a team of experts is not an expert team, because this is a clinically challenging environment. There is a lot going on. There is multi-organ support. There is a team that you have to work with. There is the weather condition, the transport condition. There is the area that you are going to visit, which could be an alien environment, and you have to deal with a group of medical professionals that you never come across before, maybe in a different country, maybe in a different continent. So this is challenging. There is a lot of technical and non-technical skills that has to be learned, and the non-technical skills are paramount in ECMO transport. These are your cognitive skills about the situation awareness to make a decision. Sometimes it's a really tough decision, and you have to be careful when you make that decision and consult your team, but somebody has to make the final decision and be assertive. There are a lot of social skills in communication and teamwork. And another area of improving the safety, that you have to have a checklist, and the checklist has to fulfill this criteria, and we covered all of this. So I would encourage every single center, if they have current transport system or if they are about to build a transport mobile ECMO service, is to consider having a checklist. This is not optional, this is a must. And you remember those days when we had the COVID and all the challenges that we had. And actually, the training and the checklist was paramount to maintain the staff, the team safety, and the patient safety. And we published this data from the Critical Care Consortium about the risk of COVID transmission to the transport team, and we came up with recommendations for that. So what's the future? How can we maintain this safety again and promote the transport of mobile ECMO? So now we are working again under the auspice of ELSO to create a registry for mobile ECMO. I'm honored and privileged to be one of the co-chairs for this with another colleague from Europe, and we are looking at all this data to be collected. All this data will be just half a page. So again, I'm taking the opportunity of this platform and having all this clinicians, ECMO enthusiasts, to be aware that this is coming your way, inshallah, hopefully, God wills, at some point this year, about your mobile ECMO data. Because we have to have this data, we need to collect it and study and learn from it and research from it. So what's your transport category? What's your transport route? What's your platform? I mean, the ambulance, the fixed wing, the rotor wing, who is in your team, and where the location of the cannulation, OR, ED, etc. And the most important two pieces of information that we are looking for, and we would like you to be accurate in them, is the activation of your mobile team and this process. And one of the advantages of this ELSO registry is that we are I would say to have a clear definition of incidents during transportations, and we classify them into this way. So having had this ELSO registry up and running, hopefully in the near future, will be another foundation for the safety of mobile ECMO. Also, what's deficient and we need to do is research, and we know the deficiencies. There has never been a level 1 evidence, an RCT, for different transport modes or different team compositions, and it all relied on this retrospective data collected from the centers. Hopefully, with the ELSO registry, we'll have more data. And also, one of the things that we are currently working on is a prospective multi-center observational study. We are recruiting for that to see the transport practice. So in conclusion, and I would say safety of mobile ECMO can be improved via a number of things. But first, as a team, you have to recruit the right people and use the suitable equipment and deploy the appropriate vehicle. So that's, prerequisites. Follow the guidelines and have a checklist. Train your team, and if you don't have enough cases, if you don't have enough exposure, do simulation, and this will help you to consolidate your practice and improve the safety of your transport. With this, I conclude, and thank you so much, everyone.
Thank you very much, Ahmed, for this great presentation and sharing your insight and working closely with Professor Bartlett in VU for that, for the guideline. It's terrific. We move to, please stay with us online because we will have question answer session for everyone after the talk. I would like to invite Dr. Akram Abdelbari, Professor Akram, to talk to us about when toxins kills, ECMO and drug overdose and toxicity. And Akram is a great friend, brother. We've been together in the SWAC for many years. I think between Egypt, Qatar, Saudi Arabia, Emirates were the first group from the Middle East to join India to expand the SWAC also. And Akram was up in front from the beginning. He is the past president of the SWAC also, and really founder of the ECMO program in Egypt. He's the godfather in ECMO in Egypt, who took it with limited resources to be really one of the top center, ECMO center, and also took the ECMO education to the next step as well in Egypt. Welcome, Akram, and the floors are yours.
Thank you very much, Ibrahim. Thank you for all people working on this great, unique webinar for 24 hours, a lot of work. I will talk about ECMO in toxicology and where is ECMO in toxicology. For a long time, we have seen many articles about poison patients who need ECMO. However, in many studies like the toxic registry, just very few of these patients needed ECMO. Out of 26,000 patients, only 10 received ECMO. And also you can see that many case reports were unsuccessful sometimes. And in this report, you can see more than 283 million admissions in 15 years in Germany. Only 49 patients needed ECMO, mostly for cardiac medications like calcium blockers, beta blockers, and antiarrhythmic overdoses. In these 49 patients, 41 received VA ECMO, and most of them they showed no difference between early or late implementation of the support. And when you see this review article coming from the French group, the algorithm talks about mainly conservative management using inotropes or vasopressors for most of cardiac patients until they are refractory or they have refractory cardiac arrest where they need extracorporeal life support. And this is the common from the guidelines, as we all know, but some toxins are common in SWAC regions that are not similar and different from other regions worldwide. You can see this case published from the UAE by Malaika and the Egyptian Journal of Critical Care Medicine about aluminum phosphide poisoning. And aluminum phosphide works as a cardiotoxic drug where it is a cytochrome oxidase inhibitor causing complete paralysis of the cardiac muscle with sudden drop in the function and a lot of myocardial injury. And also the organophosphorus compounds used as pesticides commonly in agriculture for agricultural reasons where they affect almost every part of the body, especially the lungs, the brain, and the GIT. I'll give you some examples from our center. For first patient is a 14-year-old female, 50 kilograms, who had chlorpyrifos accidental ingestion, and chlorpyrifos is used to kill pest as a pesticide in potato agriculture. She arrested twice and was successfully resuscitated. You can see her CT scan showing extrapulmonary ARDS. with a Murray score of 3.25. So she was put on VV ECMO, and you can see the saturation was 71 on maximum ventilator settings. Her rest score was 0, and the chest X-ray showed successful cannulation from jugular in this patient, and she recovered by 6 days and went back home safely. You can see here after resolution of the ARDS in 6 days. And another case with inhalational injury, a 32-year-old male who was preparing for his engagement party. He played with the helium balloons, and in 2 days he had hypoxemia followed by severe ARDS with maximum ventilator settings and severe hypoxemia. He was put on VV ECMO on 11th June last year, recovered very quickly after 5-6 days, and he was even extubated on the first day after cannulation, then went back home. Another case presentation with aluminum phosphide, and we have a lot of cases from this group. 17-year-old female, she was medically free. She presented 5 hours after ingestion of a quarter of a tablet, and it comes in the form of tablets where one tablet has 3 grams and the lethal dose is 0.5 grams. So she received decontamination measures with paraffin oil and was kept NPO because this poison, when comes in contact with water, it transforms into phosphine gas, which is the lethal weapon. And she came on huge doses of noradrenaline. You can see initially her echo was almost normal in the first day. And what we know from these cases that they deteriorate very quickly, so we put them on continuous cardiac output monitoring, and we watch them very cautiously. Then the ECG started to change with a lot of arrhythmias. After 24 hours, started to deteriorate. Then became hypoxic, congested with increasing doses of vasopressors, intubated, ventilated with rising lactate, and then arrested with pulseless electrical activity. ECMO was inserted, and you can see the echo with almost negligible ejection fraction, and the ECG after resuscitation showing a shark fin sign, classic for pan-myocardial infarction, as we can see. Then after a few days, because of concomitant hypoxia, we put her on VAV simultaneously, and the hypoxia was partly due to development of ventilator-associated pneumonia with Klebsiella multidrug resistance. On day 7, the heart started to improve, and we decannulated the arterial cannula. Then you can see some improvement in the lungs, where the venous cannula was removed on day 8, and she recovered completely and was discharged after 16 days in the ICU. The Cairo University experience in the last 5 years regarding aluminum phosphide, you can see 77 patients coming to the critical care unit, ECMO unit. The criteria for admission are concomitantly with the like a protocol with the poisons department. They come after being hemodynamically unstable, even with small dose of vasopressors. We watch them, and if they deteriorate, we put them on ECMO. The mean run duration is around 105 hours, and we can see the lactate is very high on admission, with lactate washouts usually taking around 12 to 24 hours to normalize after ECMO. You can see here the clinical data. The very huge doses of norepi and epi. The VTI is around 7. The ejection fraction ranges from 0 to 20. And we can see also that there are another organs affected as well. The Apache score for these patients was around 12 to 18. The outcome was encouraging, and 74% of these patients survived. And we can see from the logistic regression analysis that lactate after 24 hours and ejection fraction before cannulation with Apache score showed the predictors for survival. We also analyzed the ECG of these patients and echo, and we noticed after the statistical analysis that the pre-ECMO ejection fraction above 22, QTC above 318, and also mean arterial pressure, the cutoff value below 50 were significant in survivors compared to non-survivors. So there are many poisoned patients with cardiac shock and respiratory failure who are refractory to conventional intensive care measures. ECMO support can serve as a bridge for recovery for these patients, provided initiated within a suitable timing. And ECMO CPR in certain patients may provide hope if available. But we need guidelines for the area-specific poisons management, especially the common ones. These are pictures from our teams in the ECMO unit, and we do also retrieval in the long, you can see here the long, this long corridor of the Qasr Al Aini Hospital, which serves 5,000 beds as inpatients and more than 1 million admissions a year. And we do simulation courses as well, also endorsed. Of course, we develop simulators, and you can see here from the dedicated ECMO unit where after 10 years, when started the dedicated ECMO unit, we had a jump in the service all over the country, and we had done a lot of cases. Also, we have especially hybrid OR where we do complex interventions and surgeries inside the critical care unit. In the last 4 months, we have done 61 ECMO cases with a survival of around 70%. And we take pictures of the survivors on discharge, and you can see most of them are on their feet, which is a lot of work from the physiotherapists, nurses, physicians, and clinical pharmacists. We do an annual meeting, which is growing very fast, and every year we present 10 to 12 challenging cases from our ECMO patients. And we had the opportunity to live with Bartlett for many years. He visited Egypt 3 times, and he pushed us a lot from the first visit where we were just starting, and he mentioned that we should continue even with limited resources, and we should build our team, which is now a very big team. Thank you very much.
Thank you very much, Akram, for this great presentation. Our next speaker is Dr. Grace Van Louis, and is talk about When the Heart Stops First, Pediatric VA ECMO and CPR. Dr. Grace is a great friend who's pretty much been in most of all the continent also as well, Latin American and from Brazil originally, who joined Qatar now, and she's a Qatar representative in the steering committee in the SWAC also. She's an intervention cardiologist, ECMologist, that a lot of experience on ECMO and ECMO transport and retrieval, and ECMO education as well across pretty much all the continent. Welcome, Dr. Grace. The floor is yours. Thank you for joining.
Thank you so much for the kind introduction, and thank you so much for inviting me for this initiative. I think it's something fantastic. I think people all around the world are going to benefit from this. Just let me know, please, if it is in the correct way. Sometimes it goes on the presenter mode. Can you guys see this correctly, or looks like it looks like on the presenter mode?
No, it looks
I can swap
good.
displays.
Looks great. Looks
Okay.
great.
Okay, thank you so much. So as I said, it's a great honor to be here. So I have no disclosures, and the family let me use the cases of my two first ECPR cases, one cardiac and one non-cardiac, to illustrate this presentation. So we are going to start to talk about Clara. So she had a kid who had a congenital heart disease, went for a big procedure, but everything went so well. She went on the first day on post-op in the ICU with minimum sedation, low dose of inotropes, and low respiratory support, good urine output, good vital signs, pristine X-ray, blood gases were fantastic, good venous saturation, everything, dream come true, isn't it? Looked so good. So in the morning, we extubated her. We did an echo after extubation, everything showed was perfect, good biventricular function. She woke up and asked me for juice and pasta. I was on call on that day. Alhamdulillah, I only gave the juice. I didn't give the pasta because that was her ECG on the monitor at 2 p.m. and that was her ECG on the monitor at 5 p.m. So in the course of 4 minutes, she completely have ST segment changes to complete cardiac arrest. She was very agitated. We thought she was only in pain, but in the end, she arrested. So we were facing an intrahospital cardiac arrest in a pediatric patient post-cardiac surgery. So on these cases, there's a huge indication for eCPR. So eCPR is when we start VA ECMO on a patient during cardiac resuscitation or in the first 20 minutes after achieving ROSC. What we know for sure from the literature is that pediatric eCPR has been increased his use over the years. And we always start with patient selection. The patient selection on pediatric population is very diverse from the adult population. So we need to, first of all, for pediatrics, we usually do only intra-hospital cardiac arrest. We don't do out of hospital. There's one publication from my dear friend Peter that's showing that out. On also, there's only 80 cases of out of hospital pediatric cardiac arrest. And so this is not a common indication at all. So when we talk about eCPR for peds, we talk about intra-hospital. We need to think about the comorbidities, and then you need to tailor for your own program. But always you need to think about a reversible cause or a bridge to somewhere. We have to have a minimal no flow time, and the low flow should be less than 60 minutes with high quality CPR. This is an example of what we do at Cedar Medicine here in Qatar. We have this worksheet to be sure that the candidates, they meet the criteria, they have no contraindication. We do a quick MDT, and then we proceed with eCPR if the team agrees. And as we don't have in-house surgeons for cannulation, and for eCPR is only surgical cannulation, we don't do percutaneous. So we, when the team arrives, we have a pause and we see if the CPR was a high quality, and if this patient is still should, or if they arrive in time, and if they should still proceed with the eCPR. So we know by the literature that if we start in the first 60 minutes, we have a better survival, and we know how important high quality CPR it is. There's this nice paper from 2016. They were analyzing only 19 patients, pediatric patients, but they showed that if you have high lactate, low pH, low bicarbonate, and if you have increased time to start the ECMO flow, you're going to have worse results. And these results were confirmed in a meta-analysis with more than 3,000 pediatric patients, and they saw the same. If you have increased the CPR duration, increased lactate, and decreased pH, you have a higher likelihood for mortality. So Going back to our dear Clara, she had, unfortunately, the surgeon was not in the hospital, and it took her 73 minutes to be on ECMO flow. So when we are on ECMO flow, something that is very important is to think about the post-arrest care. So our job didn't finish when we placed the patients on ECMO. It finished when we get this patient home, isn't it? So when you start the ECMO flow, you have a blessing and you have a curse, because when you think about what you should do on the post-arrest, it's very easy to do with ECMO, much easier than a patient without ECMO, but sometimes you can overdo that very easily on ECMO, and then you can be deleterious for your patient. For example, it's very easy to control the temperature on ECMO, much easier than a patient without ECMO. And it's very easy to control hypoxia and hyperoxia. But sometimes if you don't pay attention, we put FSO2 too high, our patients are going to have hyperoxia. And this is deleterious. The same for hypocapnia. Sometimes our oxygenator works so well, especially in small children, that they can have low CO2. And we know this deleterious on the post-arrest moment. So we have optimized blood pressure, have a metabolic balance. We need to always look for seizures. We do continuous EEG in all our patients after cardiac arrest to be sure that we don't have subclinical seizures. We need to identify and treat the cause of arrest. And there's discussion about if you should vent the left ventricle in patients without congenital heart disease. So that's what happened with Clara. We tried to do our best. And then we went to look for the reason of the arrest. One of the emergencies, I would say, on pediatric cardiology for going for cath lab when you are on ECMO is when you think that you can have cardiac ischemia, and it was the case of this patient. There was a kink on the main left coronary artery, and she was sent to cath lab right away, and then to surgery to correct that. So these are the overall patient outcomes. They are better than the adult population. We have around 40% survival to discharge on both on the pediatric and neonatal populations. And what we know more than the discharge rate is that in a cardiac arrest, more than 10 minutes, ECPR provides better survival to discharge and better neurological outcome. And this is another very nice data collected from the American Heart Association. More than 1,000 pediatric patients with arrest more than 10 minutes. They offered ECPR to 40% of them, and these patients had higher survival to discharge as well. It was a bigger data than the other one. So this is what happened with our dear Clara. 7 days on ECMO, we sent her back to the cath lab to be sure that the coronary arteries were looking okay, and they were. The echo, we had recovered ejection fraction of the LV, and that's she talking to us. She was saying, "Hi, Auntie, I'm sending kisses to everybody in Qatar." So this is where we know patients with a cardiac disease. That's what the literature talks more about. But what if your patient has no cardiac disease? Should we still provide ECMO for this pediatric population? So that was a kid had a refractory septic shock, and she was supported with ECMO. So what we know from the literature is that there is a positive association that ECPR can improve survival to discharge, but this is still research ongoing. So most of the guidelines that we have so far, they advise ECPR for cardiac patients. Does not mean that you should not offer for non-cardiac patients, but you need to analyze case by case. We have a very nice also guideline about pediatric ECPR, and I really like this things that they say. So when you have the program, but you want to improve your outcomes, you should think about what we talked already, patient selection, but also and high quality CPR. So this is the clinical part, right, that we are very comfortable with. But we need to think about team organization, about simulation and training, and also about benchmark our processes and our outcomes so we can know how to improve. So my take-home messages in this short 10 minutes is that please don't stop believing. And these two kids can exemplify for you that pediatric ECPR, both for cardiac and non-cardiac patients, is worth it. This is how they look like today. They have 13 years old and they are doing fine. Thank you so much for this opportunity.
Thank you very much, Grace, for this great talk. Please stay with us online. We'll have questions shortly after the last session of the is Dr. Vivek Kakar from UAE. Vivek will talk us about adult ECMO and severe respiratory failure, best practice and patient selection. Vivek is from Cleveland Clinic, Abu Dhabi, who is actually the first ECMO program director in Cleveland Clinic, who is one of the founder of the ECMO program there. Also, he's the one who kicked in the comprehensive ECMO course that is run, also endorsed now, and I had the privilege to work with him closely. Welcome to the group, Vivek, and looking forward to your talk. The floors are yours.
Good morning, everyone. I probably should say good day because I know people are logged in from all over the world. Thank you very much for the kind introduction, Dr. Fauzi, and it's an honor and privilege to be a part of this remarkable tribute to legendary Professor Bartlett. I have no conflicts of interest to disclose. And I will discuss some key considerations that when it comes to patient selection for VV ECMO in adults with severe respiratory failure. We'll also highlight some common pitfalls and nuances. And although this talk is more about philosophy of care, but I will list the evidence as we go along. Now, as far as patient selection is considered, it's good to use a framework that gets you to the right answer most of the times. None of the frameworks are perfect, but this is as good as any that we use here. You need to make sure that you have the right indication, the right patient, and the right timing. And what does that mean? And a right indication is the one where you have either a recoverable acute pathology or a patient with chronic pathology who is transplantable. And we'll cover both of them one by one. And this is probably the most overused kind of framework in the world of ECMO. We make decisions because either the patient is going to receive VV ECMO as a bridge to recovery, which is ARDS from pathologies that are expected to recover partially or fully for patient to have an independent life separate from the machine. Or we do them as a bridge to transplant, where a patient on a chronic declining trajectory has been worked up and listed or ready to be listed for lung transplant. And we know that these pathologies are generally expected to recover fully. And then there are pathologies that do recover, but they can also easily get complicated and may or may not recover as well as the ones listed above them. And there are clearly pathologies that fall in the more chronic progressive diseases, and they're only to be put on ECMO if they are patients who are candidates for transplant. And we know that the trials that we use as our reference framework for our ECMO decision-making had 2/3 of the patients with primary or secondary ARDS. The transplant-eligible or chronic disease patients were not a part of these trials. But while we talk about that, I think it's worth highlighting that even by the first 15 years or by 11 years of this century, the transplant numbers, bridge to transplant VV ECMO numbers, according to the UNOS database, had started to grow quite rapidly, especially if you see after the publication of the CSER trial. And the outcomes, these are 5-year survival outcomes, 1-year survival outcomes, sorry, and they've started to catch up quite a bit. And if you look at the most recent data, and this is again, when I say recent, is only up to 2018, you see that the patients who are put on ECMO for transplant, they do perish more on the waiting list. The longer they wait, the more they perish. But when they do get to transplant, they have actually more or less similar 1-year survival rate as to their non-ECMO counterparts. But it does, even if you're not a transplant center, it does, make it important that you understand how the transplant decision-making works. Since the introduction of the composite lung allocation score since 2023, now the transplant waiting list is prioritized based on this equal attribution of these features: waitlist survival, post-transplant outcomes, and some other patient demographics and patient-specific features like height and blood type and sensitization. Now, important to note is that assisted ventilation has now super priority for lung transplant. So if you're either on continuous mechanical ventilation or on ECMO, and actually even high flow needing more than 80%, you are actually super prioritized. Now, there is a lot of debate in the transplant world whether people are using this to game the system. And so I think it's very difficult now to look at the literature and say what the outcomes of patient getting bridged is, because the sickness levels have gone down as well. But it is very important that centers who are doing routinely VV ECMO understand the common transplant barriers, because we have often been tripped by these. The patients who are BMI more than 30, those who have unrecovering AKI or CKD unless they are multi-organ transplant, or poor functional status. Any transplant center give a call after you get stuck with your routine VV bridge to recovery. These are the things that commonly trip. But so it pays attention to know these from the outset. Now, I say bridge to recovery and bridge to transplant, but there are conditions where you end up putting a patient on ECMO because they miss the normal therapeutic window, they get referred to you late from another center, they were poorly managed, or it's just there was a lack of energy behind the care. But also, sometimes you have these many rapidly progressing variants of ILD where patients just didn't have the time to get worked up for transplant. And we get these a lot of the time being a transplant center, and we end up putting them on ECMO because there are no red flags as is, and they can be rapidly worked up and listed for transplant. And that is a precondition with our transplant team, that we will only put them on ECMO if you're going to rapidly list them. But then this comes with a challenge. Yes, I mean, for the acute ones that come into this territory, they probably often need very long ECMO runs. And the chronic ones that have rapidly progressive acute presentation, if you think about the patients with MDA5 positive ILD, they often have occult malignancy. And twice in the last 2 years, we've been tripped by patients who are young, otherwise no red flags. We put them on ECMO and they ended up having an occult malignancy in the lung, and we had to delist them. So so that's why this bridge to decision is actually not a perfect decision, and one has to be very mindful, if you're putting someone on in this category. Now, who's the right patient? A right patient is someone who has no major contraindication and has a truly refractory ARDS. Let's deal with the contraindications part first. Now, I think you're all familiar that at the moment, there is really no absolute contraindication. Even this, actually, if you remove, if your patient is eligible for transplant, there is essentially no absolute contraindication. So if you look at the ELSO guidelines, the ELSO bedside tool that was launched last year, the only absolute contraindication that is if you have an end-stage lung disease and you're not eligible for lung transplant. A lot of the conditions that used to be in the absolute category have now made it to relative contraindications, and these are more essentially prompts for further discussion as a wider MDT, decision making. And why? Because how do they made it into this list? Because we got them from the trials that use the exclusion criteria. These patients as exclusion criteria. So most of the evidence from the trial doesn't directly apply to these patients who were excluded in the trials, but we know that most of these contraindications have been challenged in the recent literature. I can only discuss a handful of them. Say, for example, there are hundreds of case reports now where patients with polytrauma, actively bleeding, including neurotrauma, were placed on ECMO, VV and VA, and run without anticoagulation for a period of time with successful outcomes. So I think bleeding or not being able to anticoagulate is no longer actually a contraindication per se. Of course, you need more details. We know the patients who refuse blood product transfusion not only get successful short ECMO runs, but they also get heart and lung transplant without transfusion. Patients who are pregnant are often excluded from every single trial, actually, for ethical reasons. But we know that this category of patients actually have some of the best outcomes, both for VV and VA ECMO. And I think that's why I think when you have this category of relative contraindications, the details matter. Advanced age, yes, we know age predicts outcome in VV ECMO as good as the rest score, but where do you draw the cutoff? 45, 55, 65, 75? What matters is the details. Advanced age with the frailty, of course, that sort of starts to sound more like a contraindication. Now, obesity, everyone talks about the obesity paradox, yes, but this is because more morbidly obese people end up on ECMO when they're not as sick as the non-obese patients. What they need is a more bespoke personalized ventilation, maybe use of transpulmonary pressures. Despite that, they're extremely sick, then they're really sick and they're not going to have the paradoxical outcome that we're seeing normally with the morbidly obese patients. And same goes for every other relative contraindication that I listed. If you add the details, every cumulative information you add, it adds to the weight that you put behind that relative contraindication. Now, the right patient is also the one that has a truly refractory ARDS. What does that mean? We all know what refractory ARDS is. We use the Eolia trial criteria, so I won't dwell on that much. But just because patient meets this criteria doesn't necessarily mean they're refractory. They're refractory only because you've exhausted all the conventional tools available to you for management of ARDS patient. What does that mean? This is as good as an algorithm. This is from ELSO as any, actually. That means that patients who are hypoxic with a PF ratio less than 150 have received at least one prone positioning session, more if they actually responded. You ensure that they have a good patient ventilator synchrony. You give a high PEEP, APRV or trial or a recruitment maneuver. You echo them, and if there is a pulmonale, you do pulmonary vasodilators. And same goes for the patients with hypercapnic respiratory acidosis. Only after this, you would call them refractory acidosis. The only thing I don't see here is conservative fluid management. Actually, this is something that we're extremely rigid about. Patients should be diuresed, in a majority of the cases. But otherwise, I think this is as good an algorithm as any, and you have to use them in your guidelines so that every team member gets to rehearse them. We strongly believe, I think, having an ARDS management bundle helps. It puts a certain time-bound energy behind the different maneuvers you're going to do with the patient. We generally believe between 72 and 96 hours, you should have exhausted all of these things, and that makes a solid basis for a good multidisciplinary decision-making for these patients. So much so that when the patient gets referred to from outside, often the teams feel uncomfortable. There is an obese patient, they're not comfortable prone positioning them. We are actually very quick to just get the patient over here because we don't want to be in a position where they're still day 7, they haven't prone, and we're now really forced to go and retrieve them. An expensive and wasteful use of a precious resource. Of course, right timing matters. Yes, you don't want to go too early. This group created a lot of buzz. Actually, there was a hot topic during the COVID when the patient from this group from New York put patients on VV ECMO when the PF ratio was less than 150 instead of prone positioning them. And lo and behold, 1-year outcomes were also great. But I think if you keep doing this more routinely, you probably also see a lot more complications. So you have to take this with a pinch of salt. Now, of course, there is a group of patients who does benefit with more preemptive awake or ambulatory ECMO, and that's the patients who are going to get bridge to lung transplant. Because, say, patients with cystic fibrosis and chronic ILD, their lungs are riddled with really bad, nasty bugs, and I think there's nothing good that comes out by stirring them with a mechanical ventilator. So I think we elect a more elective and ambulatory VV ECMO helps in this group of patients. But you also need to understand that the therapeutic efficacy of VV ECMO is maximum within the first 7-day time frame. Now, we know that this 7-day that has been used in all the trials and studies has only come from observational data. And this discussion again got stirred up during COVID when we had large registries posting outcomes on the either side of this, good outcomes despite more than 7 days, bad outcomes if ventilated more than 7 days. What we now know is it is more the injurious ventilation that matters rather than actually just the ventilation duration more than 7 days. And what is an injurious ventilation? When you have peak pressures more than 30 and FiO2 more than 80%. I think what matters most is actually that you have a consistent way of approaching patients, a consistent way of making decision making, so that every team member, with the different levels of expertise, gets to the same conclusion every single time. And I think that's why you have to incorporate these principles in flowcharts in your policies and let your team, navigate them systematically. I can't overemphasize the role of MDTs. I think our own outcomes, whether it is shock team for VA ECMO or respiratory ECMO team for VV ECMO, have tremendously improved since we implemented comprehensive multidisciplinary team decision-making process. This is a study from Singapore General Hospital where you can clearly see that after implementation of ICU-led ECMO MDT, the outcomes and hospital stays for patients with VV ECMO dramatically improved. So the take-home message is that actually the single most important factor that influences the eventual outcome is patient selection, actually, and not a lot of thought process often goes behind that. The list of absolute contraindications is almost next to nothing, and even the relative contraindications are shrinking. So I think a lot of work is needed to get more details out whenever you face with what looks like a contraindication. An ideal patient, I have already explained, is one with acute pathology that is reversible or potentially reversible, and the patient has no contraindication and has received optimal medical management. And bridge to lung transplant ECMO is increasingly common. So chronic lung disease patient actually who are listed for lung transplant are actually good candidates. And we are now actually taking this upstream to our pulmonology colleagues who see these patients to put more energy behind workup of these patients and not wait for that last deterioration when we are forced to make decisions without full workup. And the role of MDTs in making the right decisions, the difficult decisions, is invaluable. Thank you.
Thank you very much, Vivek. Great talk. I think all the speakers really had a fantastic talk and time for questions. I'll start with Dr. Ahmed Labib, who also I forgot to say he's the chair of education for our SWAC also. Ahmed, it's for transport, I'm sure something will go wrong at one point, and I wanted to, if you can share with us any of the crazy moment that you had during your ECMO retrieval. If you can give us one or two, would be fantastic.
Yeah, thank you so much, Dr. Ibrahim, for this. And I remember a quote by yourself about the most perfect transportation when you sit back and chill and relax and nothing goes wrong. And this is a perfect, transport. But this is not the case when it comes to complex patients, extremes of age. For example, when you do neonates, when you do small children, and you do extremes of clinically challenges. So I'll have a case that we transferred from Vivek, actually, from Cleveland Clinic to the States. That was almost 2 years ago. And the lady was going for a double lung and heart transplant. She was tracheostomized. And almost 25 minutes after the takeoff, she started to have a bleed from the tracheostomy. She started to have hemoptysis. It was a little bit mild at the beginning, and then it increased a little bit more to become more obvious, fresh, red, obvious bleed from the tracheostomy. And as I was managing the case, the co-pilot came to me and he said, we are approaching the Iraqi airspace and there is no way for an emergency landing or diversion. You have to make up your mind now. Are we going to continue our journey or go back to UAE? And he gave me 5 minutes to make that decision. And it was a kind of, a very tricky, tough situation. Somebody who, wouldn't survive without the double lung heart transplant, or to go back, or to persevere with the team and discuss the options and manage the case and find a solution for this. And luckily, fortunately, we managed to clinically stabilize the patient and arrest the bleed, and we continued with the journey. But this was one of the very challenging moments in my career. Recently, we had a very small baby, and now he's also in the States with his LVAD, waiting for his heart transplant. And it was another 26-hour transport. And as we took off from Iceland, and Iceland, it's very difficult because of the snow, and there was another snowstorm in the States. We were very short of time. And as we reached the altitude, we heard this noise, and the bag of crisps starts to explode, and we lost the pressure because the door wasn't closed properly. And it was one of these moments in your life when you see people panicking. Are we going to land safely? What's going to happen? And despite the delays and the snowstorm in the States, we had to go back to Iceland to do another emergency landing, fix the aircraft, and then take over again. So it eventually it was good, alhamdulillah. No, the patient didn't come to any harm, but there is a lot to learn from those experiences. Thank you.
Thank you very much, Ahmed, for sharing these two interesting scenarios. I'll move to Dr. Akram, and the talk for the toxin really is very interesting. And I don't think many centers have that experience. And in many centers, you will not have a toxicology program as well. Not everyone have the luxury to have that. And I wanted to ask you a question. When if you have the history of someone overdose, or that this is great, that make your life easy, you know exactly what do they have. But if you don't have the story, when do you suspect toxin induced cardiogenic shock or any other type of shock that could be contributing to the problem? And what would be kind of way forward to, thinking of an antidote? Obviously, is great if you have the antidote. Many times you will not have the antidote and you will just continue to support. How would you dissect through that?
Thank you for this question, Ibrahim. We have a separate toxicology hospital inside Cairo University. It's around 100 meters from the ECMO unit. So the patients come to the toxicology center. They manage these patients as usual. They do their toxicology screens, and many of the toxins, like the organophosphorus or For example, the aluminum phosphide, it does not have a screening test. So it's mainly by the history. So if the patient is deteriorating from the hemodynamic perspective, they call us. We send one of our fellows to evaluate the patient, insert a central line, look by echo bedside, and then we judge if it's essential to transfer him to the ECMO unit or not. Usually, if we see that there is a high lactate, we transfer him and we start continuous cardiac output monitoring using PICO to monitor the cardiac output. And when the cardiac output starts to drop, we repeat the echo as much as needed. This is very critical time to start the support because they deteriorate in minutes, literally, after starting deterioration of the heart. So we learn this by time, and the more cases we have seen, now we are very experienced in that. Because sometimes the patients say that they took the toxin and actually they are lying. So it's part of the psychological element, and we do also for them before discharge psychiatry consultation. Many of them are transferred to the psychiatry hospital back, not discharged to home. So the protocol of management now is mature enough to get indicated or probably highly indicated patients, highly probability for indications, and not to waste the resources because a lot of patients present to the toxicology center, and now when they know that we have ECMO, so they're sending from all over the country.
Amazing.
Not only from Cairo. So we are receiving a lot of these patients in the toxicology center.
It's good that you mentioned the deterioration quickly. You know, we lost one patient. I remember similar diagnosis, cannulated and via ECMO, and then we spent time putting the distal reperfusion cannula without connecting him to ECMO, and then he actually arrested an ECPR. Was a very tragic case. But yeah, you're right. You know, I think if you monitor them early and start ECMO early, probably would be much better. Thank you very
Also,
much.
a very important sign, Ibrahim, for these patients is the heart rate. The patients who have low heart rate despite catecholamines, usually they don't do well. They don't recover. So the heart rate we have from the experience, the chronotropic incompetence is a very bad sign for survival.
Thank you very much, Akram, for shedding the
you.
light on that. And we'll move to Dr. Grace. Great presentation, Dr. Grace, again, as usual. It just, again, is the same question I asked to Dr. Nada before from cannulation perspective. Now, to have an in-hospital cardiac arrest ECPR program for pediatric might be a bit challenging, you know, and how to sustain a program like that, and what do you think of an intensivist-led cannulation? Because the intensivists are always in the hospital, surgeon not always in the hospital. How to make a sustainable intra-hospital cardiac arrest ECPR program for pediatric, Dr. Grace?
This is a very good question. Thank you, Ibrahim. It is something that I personally looked, and in our cohort, less than 10% of the patients would be suitable for percutaneous cannulation, because most of our patients, they are small, so we cannot use FEM-FEM. And they are open chest, post-cardiac surgery, sometimes complex anatomy. So in the end, the surgical cannulation for a pediatric neonatal ECPR continue to be the gold standard, I would say. Of course, if we had bigger patients, 30 kilogram, myocarditis with a normal anatomy, this would be suitable for percutaneous cannulation, but unfortunately it's the minority of the pediatric cases.
So you still have to count on the surgical colleague for,
yes.
for that.
Yeah, because we had around the 40% of our ECPR with central cannulation.
Amazing. Would you have a surgeon available at the bed, like quickly? How would you?
So
It's a bit difficult, to have
yeah.
that 24/7, right?
Yeah. So what we have now, I started the quality improvement program at CIDRA. So we are analyzing the time frame of every ECPR that we have. So we have a power form and a Cerner in our EMS. So we are recording the time of the arrest, the time of the ECMO activation, the time of the surgeon arrive at the bedside, the time of the perfusionist arrive, the time of the OR nurses arrive, the time when we cut the skin, and the time first cannula in, second cannula in, and the time of ECMO flow. So this is being monitored, and I hope in a few months there are going to be enough data to analyze, and then they're going to be able to see where we should improve. We have a general feeling that our surgeons and the team arrives very quickly. Alhamdulillah, Qatar is a small country, so people in 15 minutes are 20 minutes the most are at the bedside, so we still can be on the 45 to 60 minute time frame. So now with data, we are going to be able to analyze where we can improve on this timing.
Amazing, incredible. Thank you very much for shedding the light on that. And I will move to Dr. Vivek. A very interesting and difficult talk, really, for the respiratory failure, especially for the transplant patients. And I just have a one or two questions. One is lung biopsy. When you would you consider to do a lung biopsy, and did it change your outcome at all? Because most of the time, we get diffuse alveolar damage, and then we kept like what to do next. That's the first question. The second question would be for these patients who get prolonged ECMO run, and some of them they lose muscle, they get really weak, they have encephalopathy. And once you call transplant to see them, they will obviously be rejected. How to optimize these patients better and to make them ready for transplant? Those are the two questions for you, Vivek.
Thank you, Dr. Beck. So I'll be honest, actually, even though we do so, I think close to 40, 50 transplants a year, that biopsy is almost rarely needed, actually. But I mean, obviously, the fact is that a lot of these chronic lung disease patients have had extensive BALs, and some have had endobronchial biopsy leading up to this. But we have not needed a biopsy in our acute case that transitioned to a subacute or chronic respiratory disease. Now, having said that, the two cases I mentioned, that MDA, anti-MDA5 ILD, where one of them was a young patient, and we only did cytology from the BAL specimen from the most affected area, because these patients, they present like dermatomyositis with ILD, and sometimes they have an incidence of occult malignancy. So we do extensive CT scan to rule out any kind of thing, and you may want to do a lymph node biopsy or the lung biopsy. But that's more indicated in the older one. The older one that we had actually was 65, and they actually did have a malignancy. So though that is the only patient actually who, in my entire time here, received a lung biopsy after going on ECMO. Now, so I think, and also even, patients who come with this immunological pulmonary renal syndromes, like C-ANCA vasculitis, diffuse alveolar hemorrhages, increasingly people are moving away from lung biopsy. I think if you can get a renal biopsy is probably better, but isolated DAH with no renal involvement, then you're stuck. But I think people are really not going for lung biopsies anymore, even for those patients. Now, the second question is very important, because I think if you work at a tertiary center, you're bound to get patients who are referred to you late. So I think that's the second piece. The first piece I'll say is that what we have done is we've always been a center which does trach the very next day after ECMO. So we actually, we consent for trach and ECMO at the same time. So the very next day we will 9 out of 10 times do the trach, and which is why actually we never really went from either FEM or Avalon, because we always felt we needed as much flow as possible to allow us to do that. So we do trach straight away, and this we learned the hard way. Actually, again, coming to this, actually, when you have that question that whether the patient needs transplant or not, that's 4 or 5 points I mentioned. They always trip you: AKI, mobility, and mobility, myopathy, AKI, as well as BMI. So we've had to, so the mobility we work on from the day one. So I think that's something that we don't. And this is something that we're working with our referring centers as well. Now, there are 2 or 3 centers that routinely send us patients when they get stuck with VV ECMO. Now what they've started to do is they call us a little early. We force them to do trachs early. We get them to mobilize the patient. If they recover, they recover. If they don't, at least they come to us in a state where they can be transplanted actually. And that comes to the question about AKI, and that's something we cannot control. But we find often that a lot of these AKI in these patients who transition to do subacute and chronic is cardiorenal. And actually, and if you do more aggressive fluid management, actually sometimes the kidneys do better. It's not really true ATN in many cases. And third is the BMI, which trips these patients often. BMI more than 30, most transplant centers will flatly say no. So we've had it to modulate people's BMI with nutrition, both up and down. If you remember the case of Juma that we mentioned in our SWAC, so his BMI was 10.8. So we had to kind of work his BMI slowly up to 16 to get the transplant team to agree. And we've had patients with BMI of 35, and we know that, with some manipulation of fluid balance as well as the nutrition with our nutritionists, we can work their BMI down as well, 30 to 30. So I think those are the barriers we often face, mobility being a big one, and that's why and that's something we can control. So we attack that right from the first week of the patient going on ECMO.
Incredible. Thank you very much for sharing this insightful presentation, and thank for all the speakers. Really great presentation. Now we will move to the next session. It's last session of the SWAC also, but also last session for the whole conference that we wanted to continue, but I'm sure people behind the scene, Christine and Peter, who's awake for almost 24 hours now, are getting a bit sleepy, and the rest, obviously, of the team who's working behind the scene. So we have 4 additional outstanding speakers. Dr. Huda Al-Fudari is first, Dr. Ali At-Hussein, Dr. Mohammed Ahmed from Saudi Arabia, and Dr. Salman as well. So I'll start with Huda. Huda will, of course, everyone know Dr. Huda Al-Fudari. It's been a pleasure working with Huda and seeing how she grow and be really person who really put the SWAC also together through many struggles. She put really a lot of structure in place and really took us to a next level. So
Is she on, Ibrahim? I don't see her name.
Huda?
Are you here, Huda?
Huda, where is Huda? No, she's not online. You're right.
Do you want to switch and we can give her a text?
I will switch to Ali then. I'll switch. Ali is the next. Professor Ali At-Hussein, my great friend, one of the real founder of the ECMO program in Qatar. He is current chair for research in the SWAC also, and used to pretty much run all the research for our team in Qatar. Ali is an intensivist, anesthesiologist, trained in France. And he really one of the people who helped us to improve in prone position. He introduced prone position at workshop in Qatar, and that was really the foundation that transformed our care. We got him for ECMO, and then we started to do prone for everyone because of Dr. Ali. Ali will tell us about TB, sepsis, and unexpected ECMO in rare and deadly infections. Welcome, my friend. Floors are yours.
Assalamualaikum. Good morning, everyone. Good evening or good night for people who are from different places. Thank you, Ibrahim, for this great introduction. And really, I would like to thank the scientific and organizing committee for inviting all of us and to make this session very inclusive. I think I have to share. Okay. Can you see my slides?
Yes.
Okay. Okay. So let's start. So yeah, the title is quite long. I will try to make shorter because it's too many information in 10 minutes. So I will talk about TB and other infectious disease and ECMO in these cases. So I would love to give lot of thought and memory for Dr. Professor Bartlett about what he has done. And when you look in his eyes, in his sights, you see that he's always passing a message to us. It's something very deep in his sight. And I think all of us, we felt that, and he's still here with us over these 24 hours. So that's where we are in Qatar. And just to say that unfortunately, we had bad news from the last weeks, and we have been bombed here in Qatar, but in many places in the Gulf countries. And unfortunately, if Dr. Bartlett was still alive, I would love him to be a president of United States. I think he will be more unifying, uniting more people in the world, and to have a better community. So we'll go over the epidemiology of TB and patient in ICU and how is the evidence of TB in ECMO studies, and we'll look at the different other diseases that we might encounter in the ICU. So TB is really the first public health problem, infectious disease killing the people. You can see the geographical incidence is mainly in the south and the east of the part of the world with the big cities, with a big incidence of infectious disease and is killing people. And you can see in 2022, incidence is 10.6 million and nearly 1.1 million TB deaths were reported in 2022. So after the COVID-19 is the first single infectious agent, which is the leading cause of death. So we have many causes. So it's a silent killer. It can spread everywhere in the body, and mainly well known for pulmonary tuberculosis. And you can see that we have different types of TB, and that's a classical miliary tuberculosis we can see in the patient. We know this patient are very little number of respiratory admission in the ICU. It's counted to 1.7%. Mainly patients are very young and female as well. And we have a different severity patient who are in ICU. It means that they are very severe from respiratory point of view. The mortality of TB in the ICU is around 52.9%. And of course, the mortality is much bigger in the low-income country compared to high-income country in the ICU. So we have run a study on ECMO just to know what's going on about ECMO and what are the data that we have. We included 20 intensive care units in 13 countries between 2002 and 2022, so over 20 years. And you can see that the geographical distribution of this patient, it's a little bit the opposite of what I have shown you. It's mainly where we don't have too much TB, but main center were in the Europe. So you can see the age of this patient. We included 79 patients. The age is around 39 years old, young patient. You can see the BMI is low, so people most of the time are malnourished, and they have a long run with the disease, which affect their nutrition status. And you can see, as it was confirmed before, the SOFA score at admission is 10 at the mean. So it means that the patients were really severe, and really few of them were having AIDS, HIV positive plus another opportunistic disease. So when you look at the SOFA score just before ECMO, they were very severe, 12 of SOFA score. The PF ratio was really very low, deep as 60, 70 of PF ratio. PCO2 was as well higher, and the PI2 of these patients who were under ventilation were around 100. Tide of them were respected around 6 ml as protective ventilation, and you can see that 2/3 of the patients were on prompt position, and almost 13% were having cardiac arrest before admission. So we divided the group, this cohort in two, in cavitary and tuberculosis and miliary tuberculosis, and you can see in the red that the patient were dead and alive on the green, and then you have patients who stay for a long time after a while, and you can see that actually cavitary TB has a survival only of 46%, while the miliary TB have a better outcome. So what are the predictive factors associated with 90 days mortality? Mainly drug-resistant tuberculosis is a bad factor, and miliary tuberculosis, as we've shown, is a kind of protective compared to the cavitary tuberculosis, and of course higher SOFA score will affect the outcome. In the same time, we look at the patient from the ELSO registry, and we could identify 169 patients with having ECMO more than 48 hours in the ELSO registry. So the age is around the same. It was 39. Here we have around 40, 43, and BMI as well is quite low. Mainly, most of the time, they are respiratory tuberculosis related admission, and they were most of them under mechanical ventilation at the admission. So you can see the outcome with the survival to hospital discharge was 55%. We could not differentiate between the cavitary and miliary, but you can see that still the survival to hospital discharge is 1 to 2, so it's not as low as we might consider. It's too low. Here, in the opposite, we had a study showing systematic review and meta-analysis of 43 cases, and you can see the age are younger patient in this systematic review, and of course is counting more specific organ manifestation, and one of them is abdominal as well. So most of the time they are, and mainly here the TB is disseminated, 12 of them, and 28 were pulmonary. You can see that different configuration for ECMO, most of the time were VVA ECMO, and most of them were RDS patient, and they have a long time on ICU and on ventilation. You can see that actually the outcome of this patient were quite high, around 70 to 80% of survival, which show that there is a difference compared to our two studies. Why? Because most probably this one is a bias of publication. We tend to publish patients who are surviving. Another disease we'll talk about is the HIV, and the HIV can be complicated with opportunistic disease and have a bad outcome. This study was done in UK between 2012 and 2017. We got only 24 patients, and there was no difference between the survivors and non-survivors. And you can see that another study showed that in South Africa, 68% over survival of HIV patient, and 61 of the patient who get pneumocystis disease. Another disease I would like to talk about that we might see is leptospirosis. Just to go quickly, 40 patients in the French Réunion Island, and you can see that actually the 8 ECMO patients were 8 patients of leptospirosis were ECMO, and from the 8 patients, we had a good number of them that survive, almost 70. Sorry, 50, 55. Sorry, we have we have 6 patients over 8 patients who survived, while the ICU mortality were 23. So it's quite the same as leptospirosis related infection. Here another disease that we see in the south and east part of the world is the malaria, And you can see that most of the patients here, we have just only 3 patients were included, and 2 of them over 3 survived, and the PF ratio were very low, around 68. And you can see that all the patients, 2 patients over 3 were on prone position, 1 were on nitric oxide, and 2 survived over 3. So it might just showing that this indication might be interesting for surviving. And last is the antivirus published by our colleagues from Chile. 70 patients underwent early VA ECMO support, and the survival was 82%. So antivirus as well can be a good indication. So problem of this ECMO in TB is we have to get optimal drug dosing and pharmacokinetics. Timing of ECMO initiation in TB-RDS is important, and we should look as well at long-term outcome and survivorship. So just to finish, so young patients, most of the time, they have comorbidities, can be HIV and can be malnourished. They have usually high severity at CU admission and ECMO start. They develop high rate of complication with VAP and resistant. And miliary is better than cavitary in ECMO patient. And mortality is in the range of ARDS, but still acceptable and not higher than TB in ICU. So ARDS, TB, and other infectious disease should be considered if ECMO is available in that place. Thank you so much.
Thank you very much, Dr. Ali, for this great presentation. I'm not sure if Dr. Huda is back on the group.
Not yet.
Not yet, okay. So we will go for our next speaker. 1 second, apology for that. We have our colleagues from Saudi Arabia who is actually joining us in a very late notice. Dr. Muhammad Al-Amini from Saudi Arabia, who is Chairman of Critical Care and Emergency, Muhammad Al-Mani from Saudi Arabia, who is going to talk to us about ECMO for advanced pulmonary hypertension. And thank you very much for coming in a very short notice, really, Dr. Muhammad. He was notified only last night, actually, for that, because apology from the main speaker, Dr. Muhammad Azam. Thank you, Dr. Muhammad, for joining, and we're looking forward for your representation.
I think he put in a chat he needs a couple more minutes.
Okay, maybe we can start with Dr. Salman. Meanwhile, Salman, are you available for that? Then we will come back to Dr. Huda and Dr. Muhammad after that.
I'm ready. Fantastic.
So, Dr. Salman Abdulaziz, we all know him from Abu Dhabi meeting in SWAC also. Salman is a cardiac anesthesiologist trained between Saudi Arabia and Canada, who was originally from Bahrain. He worked in Emirates and Saudi Arabia, so he's pretty much in the whole Gulf region and supported us in Qatar in many ways, very active in research. And he was one of the main organizer for the SWAC also, very successful SWAC also in Abu Dhabi. Now he works in Saudi Arabia, and he published a very interesting paper on pulmonary embolism. And he's going to share with us his insight, pulmonary embolism on the brink of death. ECMO as the bridge back to life. Salman, the floors are yours. Thank you for joining us.
Thank you, Dr. Ibrahim, and thanks for the scientific committee for inviting me to this extraordinary Professor Bartlett Summit. Pulmonary embolism is a very important topic, of course. This is a daily base talk of the hospitals, and really we have a day without a news story of pulmonary embolism, and either in the floor or the emergency or interoperative or to the ICU level. So my objectives first is just to highlight the definitions of acute pulmonary embolism and what are the ECMO updates in high-risk patients who are having massive PE. And of course, is VTE, in particular acute pulmonary embolism, is one of the traps had been seen in any medical institute around the incidence of the VTE in hospitals around 40 to 60%, and this is the third cardiovascular cause of death, as per international registry by the WHO. So first, I want to go to the case scenario, which is related to a patient who was a 53-year-old who underwent spinal fixation. On day 23, the patient presented to the ED with witnessed cardiac arrest and asystole. So ROSC was achieved after 2 cycles of ACLS, and that time the lactic acid was showing 16 millimole by blood gas reading. And this is the immediate post-stroke transthoracic echocardiography, which was showing severe RV dilatation and dysfunction with Meconiel sign, in addition to reduced TAPC. So the patient required intubation to maintain good oxygen saturation, and he was requiring norepinephrine and dobutamine to maintain mean arterial pressure of 65 millimeter mercury, in addition to adequate tissue perfusion. And you can see that the patient was having a CT angiography, which showed bilateral or saddle-shaped PE in the main pulmonary arteries. And because of the RV failure and the need for PE definitive treatment and the possibility of elevation of the lactic acid another cardiac arrest beside the raising vasoactive medications doses, the peripheral vein ECMO was deployed. And because of the patient needs a definitive treatment, and the patient had local thrombolysis by PA catheter intervention for 48 hours, local TPA infusion. You can see the difference between the two sections of the CT scan. One is before catheter intervention, and the second one is after the catheter intervention. So day 3, the patient was weaned, started weaning. He was decannulated on day 5, and day 7, the patient was discharged to home on apixaban. A great work by this work also was published in the Chest Critical Care Journal with collaboration with international experts in ECMO field. And this is the second paper as well, which was published in the Journal of American Heart Association by my colleagues in UAE, Saudi Arabia, and Qatar, in addition to international collaboration. However, the new guidelines came out by the American Heart Association, American Cardiology, the ACC, and the ACCP, and the ACEP, in addition to the chest. It was a bit informative. However, there was some points that we need to work on for better optimization of the ECMO guidelines. So first, as we know that the PE definition, or the massive pulmonary embolism definition, is the obstruction of the pulmonary arteries leading to hemodynamic disturbance. And you know that the mortality can be at least 20% to the extreme range to 55% in the case of severe RV failure. So the cascade of massive pulmonary embolism starts with increased RV afterload, and this is because of obstructive pathology and neurohormonal pathology. And this will lead to reduced RV contractility, leading to decreased LV preload and decreased cardiac output, leading to systemic hypotension, and later to coronary decreased perfusion of the RV, leading to RV ischemia and death. We had, as you know, that the leading guidelines of pulmonary embolism were published by the European Society of Cardiology in 2019, the American Society of Hematology in 2020, and the American College of Chest Physicians in 2021. However, there was a huge discrepancy in the definitions between all these societies. Probably the European Society of Cardiology had the most, optimum definition of massive permanent embolism, which is defined as either cardiac arrest or systolic hypotension of 90, less than 90, systolic blood pressure less than 90 millimole millimeter mercury, or a drop of more than 40 millimeter mercury from the baseline for at least 15 minutes, in addition to the RV dysfunction. The guidelines also, those guidelines just mention the ECMO and the European Society of Cardiology, that patients consider ECMO in patients with cardiac arrest or circulatory failure in combination with catheter intervention or surgical embolectomy. Others did not mention anything regarding the ECMO intervention. And you can see that also the European guidelines had mentioned excellent outcomes will be in combination of ECMO with circulatory collapse or so the surgical embolectomy with the ECMO, when combined with the ECMO, will have a better outcome in case of circulatory collapse or any contraindication to systemic thrombolysis. Also, another point was mentioned by the European guidelines that the ECMO or shock team and pulmonary embolism response team must coordinate decisions. Other guidelines did not mention anything related to pulmonary embolism. However, the guidelines on massive pulmonary embolism came out by the American Heart Association and the American College of Chest Physicians. And you can see that there is a new definition came out, and they were graded to A, B, C, D, and E. And you can see that this is the red zone, which is represented by E, and it's those patients, they have prominent cardiopulmonary failure. And those in D is just pending cardiopulmonary respiratory failure. Those patients with R are requiring respiratory support because of hypoxia. And you can see that, the American Heart Association guidelines highly specified the ECMO intervention or the VECMO intervention is just, related to the category E2, and others, those in the zone of D, pending cardiopulmonary respiratory failure, were not included in the indication of the VECMO, which is a point of discussion as well. The role of ECMO in massive pulmonary embolism was established in 1971, where the first successful extracorporeal ECMO intervention was for massive PE case for a patient post polytrauma. And that was the history made for the ECMO to start with. And remember that the ECMO is the preferred mechanical support in case of massive embolism with hemodynamic support, with the hemodynamic compromise. So VECMO will help to support the pulmonary circulation and the gas exchange. However, less commonly, VV-ECMO will be indicated. So you have either the choice to proceed with VECMO with systemic thrombolysis, or ECMO with catheter intervention, or catheter with a VECMO with surgical embolectomy. This all depends on the burden of the clot in the pulmonary circulation, and if the patient is having prominent cardiac arrest, that should proceed with a better and fast, procedure to save, the patient and to reduce the RV, burden from the clot. So all these, information were taken from observational studies in addition to case series and case reports. And what was mentioned by the American Heart Association new guidelines is that if you consider introducing anesthesia or intubation for patient with massive pulmonary embolism, is just to consider the vasopressors, inotropes, and or VECMO, because those patients, they are very fragile with the introduction of anxiolytics or sedative agents, which may lead to more circulatory failure and cardiac arrest, which cannot be salvaged. The other point that was mentioned by the American Heart Association guidelines is regarding the recommendations of MCAS. So in patients with known or suspected acute pulmonary embolism on VECMO, the continuation of parenteral systemic anticoagulation is recommended in the absence of bleeding to prevent further thrombotic or embolic complications. The number two that was having a lower level of evidence is in patients with acute refractory cardiogenic shock as a result of suspected or confirmed acute pulmonary embolism. The institution of ECMO should be provided by appropriate resources when there is appropriate resources available to stabilize the hemodynamics and improve the oxygenation. In addition to in patients with acute PE, who are placed with VECMO, the usefulness of additional advanced interventions is not well established. This is because of the most of those literature is coming out from observational studies in addition to case series or case reports. What about if the patient is still not, hemodynamics support and oxygenation improvement had not yet been achieved? So this is the time for having add-on mechanical circulatory support, which can be done by a right ventricular assist device. And this decision should be taken by advanced team, cardiac anesthesia, cardiac ICU, and cardiac surgery. So the concept of the RVAD is to decrease the myocardial oxygen demand and facilitate the myocardial recovery. This is just an extra RV methodology, resting the RV by another methodology like the RVAD. And this will provide continuous pulmonary flow and add a better oxygenation if the patient is hypoxic. And just remember that if the patient is difficult to wean from cardiopulmonary bypass, is just to consider the RVAD as well as add-on intervention for the VECMO. What about the prognosis on VECMO? You can see that yet there is no adequate modality to tell about the patient prognosis while they are in VECMO. However, this paper came out from a single center study in Netherlands in 2023 and just compared the SAFE score with a new methodology, SAFE SOFA score, compared with or supported by the evidence of the RV dysfunction. And you can see that if the patient is having, this is well validated. And if you can see that if the SOFA RV score is more than 14, the 30-day survival is just 44%. And if the SOFA RV score less than or equal to 14, the 30-day survival is 74%. And this is a daily exercise on the initial 5 days to know the patient prognosis and continuum of the patient hospital course. So when to deploy the VECMO, or which modality is the best, or when, by whom as well. And as you see, this illustration is showing a lot of chaotic approach because of multidisciplinary consultations without orchestration between these teams. So the best thing is just to apply the concept of PERTs by the experts. And this is when you face a severe PE or massive pulmonary embolism, you'll activate, the ECMO teams and the PERT team together in order to achieve the best hemodynamic support by initiating the VECMO in addition to the other parallel anticoagulation or antithrombosis consultation by the thrombosis team and the other hospital services. So just to make it, better organized, if there is an acute pulmonary embolism and it is associated with cardiac arrest, is just to call the ECMO team as soon as possible to resuscitate the patient and to initiate the AP ECMO and introduce the reperfusion therapy. And if the patient doesn't have cardiopulmonary arrest, is just manifesting with intermediate low or intermediate high risk, pulmonary embolism, is the PER team will take over and will assess the patient. However, when there is any hemodynamic instability, is just to go for the ECMO team and initiate the resuscitation by VECMO. If the patient is stable, is just to stratify the risk of the patient by PC or SPC score, the RV dysfunction by transthoracic echo and or CT pulmonary angiogram. If not, okay, the patient can be managed as outpatient. However, if the patient is having high risk, SPC score or RV dysfunction, is to go for another assessment level by measuring the cardiac biomarkers, whether the proBNP or the troponin. And if the biomarkers are elevated, is just to hospitalize the patient with close monitoring. Any deterioration is just to call for the ECMO team immediately. If the biomarkers are not elevated, the patient can be admitted to the floor without, close monitoring requirement. However, just there is a close relationship between the ECMO team and PER team, and harmonization is just to harmonize the relationship between the two sides in order to achieve the best goals of care. And last is this is another illustration of PE, approach. Remember that when the patient is in shock or cardiac arrest, this is the best approach to be proceeding with the patient, in sequence. In summary, massive PE is a life-threatening emergency, and VECMO is the optimum rescue intervention in those particular cases. Add-on mechanical resuscitation support should be considered on time, and massive management of massive pulmonary embolism is by multidisciplinary approach as always. And remember that, and just going through all these, literature. What I think is more comprehensive and focused guidelines are needed regarding the ECMO approach in massive pulmonary embolism by the ILSO is required. Thank you very much.
Thank you very much, Dr. Salman, for this really great presentation. Please stay with us online. We'll have question sessions after that. And our next speaker is Dr. Muhammad Al-Mani from King Fahd Medical City in Riyadh. He's one of the founder of Saudi Ministry of Health ECMO Service. He's also Saudi representative of SWAC also. His area of interest is resuscitation and ECPR. Dr. Muhammad also is the Director of Critical Care Service and Emergency in King Fahd Medical City. Again, thank you for coming in a very late notice to talk us through ECMO for advanced pulmonary hypertension. The floor is yours, Dr. Muhammad. You are welcome.
Good morning, everybody. Thank you, Dr. Ibrahim, for the nice introduction, and thanks for the committee for the invitation. I have nothing to disclose in this topic. Pulmonary arterial hypertension is a progressive disease involving proliferative remodeling of the pulmonary vessels, which will lead is associated with a high morbidity, mortality. Acute pulmonary hypertension decompensation usually is unpredictable and potentially can lead to refractory right-sided heart failure, and then it might go into a spiral of death, which is unfortunately. Whenever acute decompensated right-sided heart failure happen, it carries a negative prognostic event in the course of the pulmonary hypertension patient. So pulmonary hypertension impacted the heart in both way, affected the right-sided and the left-sided because of the vascular remodeling and vasoconstriction and impaired pulmonary artery compliance. This will be reflected back on the right-sided of the heart, where there will be the right ventricle is going to act against higher resistant, and this will lead to RV hypertrophy, reduced contractility reserve, and then it might lead to dysfunction, failure, and dilatation. Then it might lead to increased high CVB and systemic congestion. Because of the dilatation, this might lead to impact on the left side of the heart, where it might have pushed the septum to the left ventricle, and leading to a chronic underfilling of the left ventricle and some atrophy, and it might lead to impairing of the coronary perfusion as well. And at the extreme, it leads to systemic low output, cardiac output. So looking to the two diseases, from the physiology point of view, it's either acute PE or pulmonary arterial hypertension. They probably, both of them is leading to acute right heart failure, which impact the left ventricle. But in a high risk acute PE is an abrupt pulmonary vascular obstruction, which lead to sudden RV after low jump and septal shift and low systemic cardiac output, while decompensated pulmonary hypertension is a chronic pressure overload that drive RV, PA, uncoupling, then acute decompensation, venous congestion, end organ, then hypoperfusion. In general, PE need recanalization. PH usually need transplantation and unless there is a clear reversible causes for these conditions. So we, as an intensivist, we need to be more cautious with the acutely decompensated pulmonary hypertension patient. We need to detect the right-sided heart failure, and we ensure appropriate monitoring and some expert management in these cases. We try to avoid intubation if we can, because this really have bad consequences in this acute pulmonary hypertension patient. We have to treat the triggering cause like arrhythmias, pulmonary embolism, and optimize the fluid removal and reduce the RV afterload, and probably inotropic plus some vasopressor management. If all of these has been failed, then there are probably two trajectory for this. Is either this patient is not candidate for transplant and just supportive care, or if he is a candidate for transplant, then probably ECMO might have a role for this patient for bridge them to be transplant. So extracorporeal life support has went through a process of journey in a pulmonary hypertension between 2005 to 2024. Initially, ECMO was used as a salvage procedure. It would be probably deployed as the last resources in a refractory PH patient. And with that, the mortality was really very high, 70%. Then landmark study demonstrated that careful selection for patient could be successfully bridged to a lung transplantation utilizing ECMO with a good successful rate that was in 2013, and that was probably paradigm shift in the field. And then 2017, the concept of awake ECMO has been initiated, which is probably it would facilitate physical physiotherapy, avoid the ventilator-associated complication for these patients who's awaiting the transplant. And then in the 2018, The World Symposium of Pulmonary Hypertension formally defined ECMO framework in the management of pulmonary hypertension, and they do establish some consensus for these cases. And 2023, it has been integrated as a part of the transplant. And the seventh WSPH is updated the consensus for that and made the ECMO as a part of transplant candidate acute pulmonary hypertension decompensated patient. It should be considered before refractory hemodynamic. Probably it would be more helpful. Definitely there is a better outcome with an expert center. They do recommend to go for awake as a standard for this group of population. So it has been moved all the way from salvage to bridge to transplant. Then we adapted the awake ECMO and then became already a standard for a patient who is candidate for a transplant. Looking to the evidence, so in a severe PH cohort patient, 123 patient was listed for transplant. 28 needed ECMO as a bridge. 1 year graft survival was 82 compared to 88, so it was a comparable graft survival, and 5 year survival was almost similar, 54 versus 59%. So it does help with the graft survival as well. They do notice that when we use it as a bridge, it had longer ICU stay, more than, and the patient needed to go for more thoracotomy and vascular complication. Considering some of the complications that might be happening for this patient, that we need to be ready for it, is the bleeding complication is the major problem with these cases, and usually it happens in up to 82%. Major bleeding was almost near to 50%. Some vascular complication, it might reach to 30%. So we need to be ready for these complication as well. For a patient who went for a bridge to transplantation. So ECMO as a bridge to recovery after lung transplantation as well. It has been evolved more and more as the time goes, and we can see that there are more patients is being used as intra and post-operative ECMO as a bridge for post-transplantation. This would help the left ventricular remodeling post-operative and recovering. And the evidence shows that intra and post-op, they do have a better survival compared to intra-op patient. Other option that, or other areas that ECMO can help is a bridge for endarterectomy for CTEPH patient. There are severe, these patients might have a right ventricular failure due to the CTEPH, which can be treated surgically with endarterectomy, and ECMO can be used as a bridge to urgent pulmonary endarterectomy and recovery early post-op. And we can see evidence that as years goes, there are more and more utilization of ECMO, and with more utilization of ECMO, the mortality has came down from 34% almost to 4%. Would ECMO had a role probably in the future for a bridge to recovery in pulmonary arterial hypertension, with the new more therapies that's coming up for pulmonary hypertension? So it might be an option to be considered and utilized at this moment. for this group of population, especially for a patient who's not been started on a treatment for pulmonary hypertension disease. It might have a role, but at this moment, it still has to be choose wisely and not liberal. So it can be used in very exceptional situation in a patient who has not been received any specific treatment for pulmonary hypertension, especially with a reversible situation that temporarily worsen the right ventricle, like going to the surgery, pregnancy, or maybe some arrhythmias. This is a study looking to a case series of or multi-institutional synthesis of 36 case report cases for severe pulmonary artery hypertension in a pregnant and postpartum patient, and they do found that the maternal survival was 58%, which was previously pre-ECMO era, it was around 30%, so there is an improvement in the survival. Majority of these cases underwent a cesarean section, and the neonatal survival was 100%, and this is probably due to the decoupling of fetal outcome from the maternal hemodynamic crisis. So ECMO around the transplant for severe PH, we have to refer early prior to the crashing, trigger the planning, especially when you have a patient who is in a shock, in a cardiogenic shock. Consider awake bridging, that's better, intra-op VA ECMO, and probably post-op VA ECMO. This will allow the LV conditioning and control weaning after the pulmonary vascular load is off. ECMO fit in pulmonary hypertension, it can establish a role to a bridge to a lung transplant in an expert center. It can be a bridge to recovery in very occasional and should be limited to truly reversible trigger and rapidly effective therapy, like what we mentioned in the pregnancy. We should not utilize ECMO in the end-stage disease without transplant and recovery path. Awake non-intubated support is the preferred and when feasible for these patients, because it would allow for rehabilitation and hemodynamic stability. So we should always consider the exit strategy before we open the cannula for pulmonary hypertension patients. With this, I conclude. Thank you very much.
Thank you very much, Dr. Mohammed. Really a great talk. I think it's our first interaction together. I tell you, great presentation, really. Very thoughtful, very details. Please stay with us online. We'll have a bit more question answer session shortly. And we have Dr. Huda Al-Fudari joining us for the final talk of the SWAC ELSO chapter. I have to apologize that we have a full session for Euro ELSO after us. So please stay tuned. SWAC ELSO is not the last for this symposium. Dr. Huda Al-Fudari is anesthesia intensivist trained in the UK, very experienced also in pregnancy and women health as well. She is the current president of the SWAC ELSO. She come a long way in the chapter, and with her leadership, our chapter really becomes stronger and stronger. She will tell us today about what ELSO expects, how centers can meet international standards. Dr. Huda, welcome on board. The floors are yours.
Thank you very much, Ibrahim, for the kind introduction. And I'm really honored to be part of this virtual summit on Robert Bartlett Legacy. So my talk is going to be on ELSO expectations, how ECMO centers can meet international standards. These are my disclosure. I'm the current chair of SWAC ELSO chapter. I'm also a member of the ELSO board. In the next 10 minutes, I'll give you an outline about why ELSO standards matter, what are the core expectations for ECMO centers. And I have divided them into what I've called the 5S model, talking about S for space, staff, systems, safety, and surveillance. So I'll start with the vision and mission of ELSO. ELSO's vision is to be the premium organization for the advancement of extracorporeal life support globally by providing leadership through innovation, advocacy, and advancing knowledge. And in order to achieve this vision, also have set standards in different domains. And standards are very important, as we all know, because standardizing any practice, not just ECMO, but any practice globally, will result in the improvement in clinical outcome and ensuring patient safety. And one of the areas that also has been introducing is the center certification, which looked at different domains in the introduction of your ECMO program, which looked at the development of the program, the financial resources, the care protocols, how the process improves, and the registry and leadership. So, as I mentioned, I have divided them into 5 domains, the 5S model, talking about space, which is where the care happens, the staff, who delivers the care within your center, the systems, how this care is delivered, the safety, how the risks are controlled within your center, and finally the surveillance, which is how performance and quality are measured within your center. So talking about the first S, the space, where are you going to provide this service within your center? Also has produced these guidelines for ECMO centers, which talks thoroughly about how centers can start and gives you lots of information about the space. So talking about the level of the ICU, it has to be in a tertiary center, where the ECMO unit is located. Is it within the ICU, or at least it has to be in close proximity to it, to make sure that you have all the supportive services, and you should have all the subspecialty services available to look after the critically ill patients. It talks also about the total number of cases per year, and we know that volume does matter. The larger the number you do, the better the outcome. And there is a minimum number of cases that you should do per year in order to maintain your skills and the expertise of your team members. Transport facilities are also important within your center, because ECMO patients will need to be transferred to have imaging, to have procedures in the OT, so you should be capable of providing that within your center facility. The next S is the staff. Who's going to deliver the care? And we're talking here from the top, the leadership, the center director, and the coordinator, going down to the different members of your ECMO team, including the ECLS specialists and ECLS physicians, as well as all the multidisciplinary team members, including the dietitians, the physiotherapists, the clinical pharmacists, etc. All these members should have credentials, and they should have set roles and responsibilities which are documented very well as implemented. The staff cover ratio is also important in your center, whether you're giving the single caregiver model with the ECMO bedside, ICU bedside nurse is the same as the ECMO specialist, or whether it's going to be the specialist to pump ratio, where you're going to have a bedside nurse as well as an ECMO specialist that looks after one or more than one pump. You should also have an in-house 24-hour cover within your center that is available instantly for any emergencies that may arise. Under staff also comes training and competency, and this is one of the most important part in your center development. Each center should have an initial educational process to qualify the team to manage ECLS patients, but in addition to that, you should have also an annual education process to maintain the credentials that you obtained in order to manage these ECLS patients. And this training will be in the form of lectures, water drills, low and high fidelity simulation, in addition to the bedside management and minimum patient requirement. You also should have the ability within your center to educate and train new members of the team. As we know, we have turnover of staff, we have new members joining, so we should be able and capable of training them to the standards. This is the ELSO ladder for education. And this is what you need to do in order to apply for the also adult ECMO practitioner certification exam. It starts with a didactic course that covers all the curriculum set by ELSO, followed by the simulation lab training, both low and high fidelity. And then after you finish this, you go for the bedside experience, which should be a minimum number of hours at the bedside, proctored hours under the supervision of a qualified personnel. And to get the first and second step, the didactic course and simulation lab, you can achieve that by going to any of the ELSO endorsed courses, which are available globally. You can see there in the map, they're everywhere there in each chapter of ELSO. Not just that you have to train your team, you also have to work on your training faculty. You need to build up a regional faculty within your chapter or your region who can deliver ECMO education in a standardized way. You have to have a standardized curriculum and deliver the training, whether the skills, the low and high fidelity simulation, in a standardized way. And you can achieve this again by attending any of the Train the Trainers courses that are available globally. We had it in Abu Dhabi last year in SWAC ELSO. I know this year it's happening in Barcelona, and I know both AP ELSO and LATAM are planning also to host it soon in their chapter. The debrief skills is a very important skill that your center members has to have as part of their ECMO education as well. The third S is the systems, how care is delivered. So now we have the place where we're gonna provide the ECMO service. We have got the staff, we have trained the staff. How are we gonna deliver it? We need obviously the equipment and the technology. And also again has issued these guidelines for ECMO centers, which highlights it in detail about what equipment you need in order to start up the service. But it's not just the equipment for the patient, it's also your backup equipment, how much you have, where you're going to have it placed in order to be available for any failure in the equipment. You need to be able to maintain this equipment. You also have to have a surge capacity like we had in COVID-19 so that you know how to cover the service in an affordable way. How care is delivered is also involving the program structure. We talked about the different members of the team. Now, each member will have their roles and responsibility, and they will be executing them separately, but in the same time, they have to coordinate it with the other members of the team. ECMO is not a machine. It's not the machine that's going to treat patients. It's how the multidisciplinary team interact with each other in the management of the patient. So there should be coordination and communication between each member of the ECMO team. The 4S is safety, how risks are controlled. And this can be demonstrated through the enormous number of guidelines that are produced by ELSO on the different aspects of care. And one example, the patient selection protocols, which allows you to select the right patient for the right procedure without subjecting the patient to the risks unnecessarily if the therapy is not going to be useful for them. The last S is the surveillance, how performance and qualities are measured. And this is really the icing on the cake. So you've set up your center, you've started your service, and you have achieved the bare minimum to provide the service. But now you have to do the fine tuning where you're going to provide a higher quality of care. And the ELSO Award of Excellence is a great example or guide in telling you how you achieve that. If you go to their application and just read the questions, this actually gives you a roadmap into how to fine tune your program and reach clinical excellence. And it involves a number of aspects. We're talking about the ELSO registry, for example. The ELSO registry provides you, there is an annual report from ELSO, which gives you the outcome data globally. And then you can see what your outcome data in your center and benchmark it with the international community. Another important and useful platform is the ELSO quality reporting platform, which is used by center as a benchmark to monitor the performance, not just for your annual survival, but also it gives you more details about the different aspects of your care, including the different complications and their rate, and you compare yourself to them. And this will allow you to continuously improve the quality of the service, and you can review your process if needed. If you're substandard in one area, then you need to go and study it, revise it, and then make a plan for improvement. Maintaining the knowledge of the current ECLS practice is very important within your center through annual competencies that all your team members has to undergo, and also through attending annual conferences and educational opportunities like this one that we're having today in order to stay up to date. Staying up to date with the recent publication through journal clubs, through peer review and M&M meeting is also important. Another important aspect of your center is engaging with the community, whether within your center and connecting with each other as members of the ECMO team or engaging with the outer community. And this is quite important for a center also to hear back from your staff to see whether they're happy with what they're doing, whether they have any concerns. Psychological safety is very important, and we have to engage with them and make sure that we are connecting and improving that aspect as well. And it's not just the staff, it's also the patients. We have to think about providing the patient-centered care. We need to listen to our patients, meet them, do the patient surveys and feedback questionnaires to listen to their recommendations and what is going to be, what is it that they like to have as a patient and as a family in order to provide the best care that we can for the patients. And we're doing all this really in order to provide a high quality ECMO service to our patients and also to continue Dr. Bartlett's legacy. And with that slide and his quote, I end up my talk. Thank you very much.
Thank you very much, Dr. Huda, for this great presentation. Now it's a question and answer sessions, and then we'll have a conclusion from myself, Dr. Huda, also as the president of the SWAC also. So I'll start my first question for our first presenter, Dr. Ali. You gave a very nice talk really about ECMO in TB and also other diseases like leptospirosis and HIV. And, you know, TB in general, people try to stay away from these patients on ECMO because they think about cachexia, they think about, multi-organ involvement for miliary TB and so on, cavitary lung lesion, that they might not be a transplant candidate. There's always this, fear to put this patient on ECMO. Sometimes they are right, sometimes it's wrong. What would be your strategy, to say, okay, these are the patients that we definitely should not put on ECMO with TB, and some that's specific for tuberculosis that you'll say, actually, we should go beyond and try to save them. What would be your strategy going forward for that, Dr. Ali?
Thank you, Dr. Ibrahim. I cannot put my camera because I think I'm not allowed to. I think it's a difficult question because these patients are usually young, and as we showed, they are sick. So with high SOFA score, they are very hypoxemic. And they might have other comorbidities, HIV and so on. So I think it's difficult to really respond, and it's really case by case. But the meaning, and you can see we have not too many patients, 79 in our retrospective study, 169 in the ELSO registry. So it's not very common, but you might have 2 or 3 bad experience, and you think that you will get, refute or recuse all the patients who are on TB, and that was actually the question about the studies. And we just showed that actually still the mortality and the survival is quite acceptable. So I think we should propose to this type of patient, whoever they are, because it's very difficult. It's a reversible disease. Maybe what we show that the patient with cavitary and having already a resistant strain of mycobacteria, maybe that's what makes refrain, but it's not pure science to say yes or no.
Thank you very much, Dr. Ali, for this feedback. Dr. Salman, a quick question for you. Pulmonary embolism in a cardiac arrest situation is one of the very difficult, challenging time. Particularly in our center, our survival is actually not very good, especially after TPA is giving. We have many hemorrhagic shock complication that unfortunately was not a favorable outcome. And I just wanted to I'm sure there's no much data on that, but is it wise to consider for cardiac arrest straight ECMO, not TPA? What's your experience on that, and what would be your direction?
Yeah, very difficult question. However, as you mentioned, there is no data available in regard of cardiac arrest related to suspected or confirmed acute pulmonary embolism. So the European Society of Cardiology recent guidelines were saying to give half dose during the ACLS protocol in order to achieve ROSC and better survival. However, as you mentioned, there is the risk of bleeding. And there was one review from published in the JACC journals, okay, about patients with cardiac arrest due to massive pulmonary embolism. Would you proceed for ACPR? So the question was related to if there is uncertainty about the brain or neurological status, is to go for ACPR. If you know that the patient had, worsening neurological status prior to the cardiac arrest, that would unfavor the ACPR intervention. It's very difficult to say yes or no. It's a question about a pro and cons debate, maybe at a conference level. However, if you have a strong team with very, practical team dynamics between the ECPR team and the cardiac surgeon, remember that the patient will reach to cardiac arrest status because of the clot burden and the pulmonary circulation, and that will not be relieved by systemic thrombolysis, and that will not be relieved by catheter intervention. So if you have the cardiac surgeon available, do ECPR, take the patient immediately to cardiac surgery.
Thank you very much, Dr. Salman, for this feedback. We have a question from the chat for Dr. Al-Mani Mohammed from Dr. Felix Hennig. And his question is, given the long waiting times for donor lung, how do you cannulate for decompensated pulmonary hypertension?
Thank you very much. Usually this patient is better to be cannulated percutaneously, and it's better to be, femoral usually, VA ECMO, because this is easily to be deployed and easily to be done in awake patient. And ideally, we wanted this patient to avoid the mechanical ventilation and do it in awake patient, so we can maintain the rehabilitation and avoid the mechanical ventilation consequences in these patients.
How about the new cannula, the one from the jugular to the pulmonary artery, Protect Do or other? There's different new cannulas that go to pulmonary artery straight. We tried it once in actually one of our patients, and just give you this freedom. You free the groin, give you a longer duration, and you can stay longer on it. Do you have any experience with that or not yet on that, Dr. Mani?
We don't have experience, but going through reviewing the topic, the problem here with the pulmonary hypertension, we do have a high resistance in the pulmonary pressure. So it might relieve the right ventricle a bit, but it would not resolve the problem for the pulmonary artery hypertension. So the problem will be remain. So the other approach that some of the centers would be doing is doing pulmonary artery to the left atrial cannulation, and this would not require a bump, and it would help this type of patient.
Interesting. Thank you very much, Dr. Mani. We are actually finishing on time nicely. Dr. Huda, I think a great shed light about the also expectation. I thought maybe we can take some time. You can reflect on the SWAC also chapter, development over the years, how Professor Bartlett influenced us, to come together. And I'm sure he will be very proud with us now coming together despite all these difficulties, continue to grow. Would like to hear from you, your thought on that, Dr. Huda.
Thank you, Ibrahim. Yeah, I think we all know Dr. Bartlett influences all throughout our whole career, since each of us have been involved with ECMO, ELSO, etc. I think with regards to SWAC ELSO, definitely there is a huge expansion in the chapter, and there is a huge development, and it's great to see, all the participation today and also throughout the annual conferences, and how it's getting bigger and bigger every year, and how we're connecting more and more as well every year. I think education is one of our strengths in our chapter. We're very proud to have 7 ELSO endorsed training courses within our chapter. All of them are fully comprehensive ECMO courses, which qualify for step 1 and 2. And this reflects really the passion as well as the quality of ECMO education that we deliver in our region. With regards to Robert Bartlett, I guess, as I said, we all have our own encounter with him and his own influence in his way. Maybe I can share some of mine. I remember several, encounters. One of them that come across me now is I remember when I invited him once to attend our first ECLS symposium in Kuwait. It was 2019, I think. And for some reasons, he had some health issue where he had to apologize and could not attend, which was totally understandable. I met him 6 months later in South Africa in the steering committee. I just went into the room. The meeting was about to start, so I just sat down. I said, waved hello from a distance, and I just waited for the meeting to start. And I didn't even have a clue that even if he recognized me or know who I am, it was like just my early years in the chapter. And he stood up. He came all the way. He was sitting the opposite side of the room. He came all the way to me. And he just leaned forward and he said, "I'm really sorry I couldn't attend your event last September." And I just was totally, kind of amazed that that he recognized me, B, he remembered. I'm sure he gets, hundreds of calls to attend meetings all over the world. But he actually remembered that. And this taught me humility and taught me how, that it made a huge difference to me as an individual. And I still remember it till the day I'm sharing it with you today. And taught me that, every time you have an encounter with somebody, these little words that you tell them, they make a difference to them. That's what he taught me. Another thing
Absolutely.
I remember was when I was giving him the title of his talk for Kuwait when he was coming to talk in the SWAC also. And he was talking about the challenges during ECMO. And I called it "The Dark Side You May Not Know." That's the title I chose for him. So he emailed me back and said, "It is not a dark side. It was very challenging and interesting for me. So I would change the title." Again, that taught me passion. He had a passion to what he was doing. And he really enjoyed, despite all the challenges that he faced throughout all his years, without that passion that he had, he wouldn't, have got us all to where we are. So that's what I'd like to share about Dr. Bartlett.
Thank you very much, really, Huda and speaker. I think we're coming now to end of our session for the SWAC also chapter. And I wanted to really maybe reflect on the breadth and depth of ECMO practice in our region. We discuss really many interesting topics, from managing complex infectious diseases such as dengue, tuberculosis, HIV, addressing the resilience of resource-limited setting, where innovation, adaptability are really essential, highlighted by Jana. We explore a critical area like transport, both within countries, across countries, and advanced application of ECMO, ACPR, and adult, pediatric, one program. Pulmonary hypertension, we're very well covered, echo CO2 removal, all the way to transplant, managing pulmonary embolism and toxicology. What stand out is really not just sciences, I think, is us coming together, showing resilience, collaboration, commitment across our region. It's really very nice to see that. And despite all the challenges, we still continue to work in a very high level. I would like to really extend sincere thank for all the speakers who really share their expertise with us, their dedication, their willingness to share the knowledge, but also for other speakers who couldn't make it, because we have a very large number of speakers who could join. Would love to thank the audience who stayed with us across all the sessions, and obviously for the organizer, all the fantastic group behind the scene who kept us on time and check and put all this together, make it really, really easy for us. And finally, as we close, it's back to the legacy of Professor Bartlett. His legacy is not only about the history of ECMO, really, it lives with us every day, with the team we build, with the patient we treat, with the knowledge we share, with the training that we do, every time, it's his legacy continue. Every life saved on ECMO is continuation of his legacy, really. And as long as we continue to work together, his vision will remain alive through all of us. So I would like to thank you all, and stay tuned for the Euro also is coming. Nick is really who's the founder of this idea, of this symposium. I have to thank him for putting this together, obviously. And Euro also is coming next. Thank you very much, everyone, for this opportunity. It's a privilege to be part of this team.
Congratulations to the SWAC ELSO chapter. That was amazing. Thank you all so much. With that, we'll take a short break, and I see we have Nick Barrett. He'll be starting things off at the top of the hour. So we'll just take a little break here and come back soon. Thanks, everyone.
Thank you.